You want to start, sir? Okay. Check 1, 2. Mic test. 1, 2, 3. Check test. Check 1, 2. Test 1, 2. Mic check. 1, 2, 3. Check. Check 1, 2. Okay, done. Check 1, 2. Mic test. 1, 2, 3. Check. Test 1, 2. Mic check.
Hello. Hello, 1, 2, mic check.
Check 1, 2. Mic test.
Hello.
Hello?
Hello, 1, 2, mic test.
Yeah. Okay.
It's okay?
Yeah. Check 1, 2. Test 1, 2. Mic check. Prakash. Prakash,
Hello.
ఓకే.
హలో,
ఇప్పటి నుంచి ఐఎంహెచ్ ఇక్కడ రెండే సైడ్ బై సైడ్ విండోస్ అంతే.
నీ వాయిస్ క్లియర్ అవ్వట్లేదన్నా మళ్ళీ.
వస్తుంది, డోంట్ వరీ. చెక్ 1 2 మైక్ చెక్ 1 2 3 చెక్ టెస్ట్ చెక్ 1 2 వాయిస్ అన్న చూడు.
హలో,
చెక్ 1 2
హలో, మాట్లాడు ఒకసారి.
ఓకే డన్. చెక్ చెక్ 1
రావట్లేదు.
1 2 3 చెక్.
హలో,
హలో చెక్ 1 2 మైక్ టెస్ట్.
ఇది ఓకే.
ఓకే కదా. చెక్ 1
కంటిన్యూస్ ఏదైనా మ్యూజిక్ ప్లే చేయి.
వదిలే, స్టార్ట్ అయిపోతుంది. చైర్మన్ వచ్చేసారు, స్టార్ట్ అయింది.
కరెక్టే, కానీ వాయిస్ క్లారిటీ లేదు, క్లియర్
చెక్ 1 2 మైక్ టెస్ట్.
లేదు.
చెక్ చెక్ 1 2 మైక్ టెస్ట్ 1 2 3 చెక్.
హలో,
Check 1 2 mic test 1 2 3 check test 1 2 mic check 1 2 3 check test 1 2 mic check 1 2 3 check. Test 1 2 mic check.
హలో.
Check 1 2 mic test.
నీ వాయిస్ అన్న ఏం లేదు, నీ వాయిస్ కట్ కట్ అయ్యి వస్తుంది.
ఓకే, ఇక్కడ కొంచెం చిన్న ప్రాబ్లం, నేను చెక్ చేసుకుంటుంది.
ఆ ఏసీ ప్రాబ్లం ఉందండి. అన్న 1 సెకండ్ మళ్ళీ చెక్ చేయవా? హలో, హలో,
Check 1 2
హలో,
check 1 2 test 1 2 check 1 2 test 1 2 mic check check 1 2 check.
ఒకసారి మన వాయిస్ ఎలా వస్తుంది వేణు? హలో, నా వాయిస్ క్లియర్ కదన్న మీకు?
నీ వాయిస్ క్లియర్, నో ప్రాబ్లం.
నీ వాయిస్ ఏంటంటే అంటే ఇది వాయిస్ కట్ అవుతూ ఇట్లా వస్తుంది కదా, అంటే బ్యాటరీస్ డౌన్ అయితే ఎలా వస్తుంది చూసావా?
బ్యాటరీస్ చేంజ్ చేసేస్తాం, వాల్యూమ్స్ అన్ని సెట్ చేసేస్తాం.
బట్ సేమ్ అలాగే వస్తుంది మళ్ళీ.
ఓకే, చెక్ చేసుకో ఇప్పుడు సార్.
Welcome to the post lunch session. from SVS Medical College. This is IPS TSB Awards.
Check 1 2.
For the Pudu Chinnareddy Venkatramama Award.
Check 1 2.
Hello. Yes. From SVS Medical College, we are having Pudu Chinnareddy Venkatramama Award. This has been instituted by Dr. Raghurami Reddy in memory of his parents in the year 1983 by contributing to the society rupees 1,116 initially, and subsequently an additional 25,000 was added. Any member of IPS Telangana State Branch is eligible for the award. Research work should be submitted for the award presentation. Cash prize of rupees 2,000 and certificate will be given to the best paper of the session. We have three presenters, Dr. Vishwak Reddy, Dr. Naveen and Dr. A. Ravina.
Hello.
For each presenter will give 10 minutes, 8 minutes for presentation and 2 minutes for discussion. Now I request Dr. Vishwak Reddy to come and present his paper. Questions can be raised from the chat box, please.
Can I start, sir? Can I start, sir? Yes. Can I start? Yeah. Good afternoon, everyone. And today I'm Dr. Vishwak Reddy, and today I'm going to present a paper with the title Impact of Media and Time Management Pattern on Mental Well-being Among General Population During COVID-19 Lockdown in India. So COVID-19 is a public health emergency. WHO has declared this to be a pandemic in March 2020. To combat this, India and many other countries imposed nationwide lockdown. In India, it was between 25th March to 31st May for about 68 days. And really, it was an unprecedented experience for all, faced by new challenges to deal with, along with unexpected changes in the lifestyle, which could definitely impact the mental well-being of the entire society. So there are many studies which have been done during COVID-19 lockdown, and they screen from anxiety, depression, and stress from the perspectives of social demography, health status, behavior changes, and precautionary measures. But few other domains are missing. So one of the important domains is impact of media. There were very less studies on it. So most of the individuals being housebound and media being only major source of information during this lockdown, it could definitely impact the mental well-being of society. And most of the individuals, due to the lack of a usual routine away from their occupation, outside social and recreation activities, they are provided with a lot of extra time. And there could be a pattern of duality in how this time is being spent. And definitely it could impact the mental well-being of an individual. So hardly there are many studies that have been done so far on time management, but few studies were done from other countries in the impact of media, but not from India. So with this background, the current study is done to analyze how media and time management pattern affect the mental well-being of general population during the lockdown. Coming to our methodology, so after ethical committee clearance, an anonymous online questionnaire containing 67 questions were disseminated to student, employee, association member, friends and family groups of researchers using social media, and they were encouraged to pass it on to others across the country from 1st April to 12th May 2020. An informed consent was provided, mean time was 10 to 12 seconds, minutes, sorry. So after reviewing many studies on previous pandemics, we developed a self-structured questionnaire with the following domains, and these domains I'll be explaining in the results. And mental health status was screened using standard reliable DAS 21 scale. And once the data is obtained, we have done descriptive analytical statistics and nominal ordinal data comparisons were done using chi-square and Mann-Whitney, and associations were established using Spearman correlation. Coming to our results, so we received 891 responses during this study period, and this is a distribution of the study sample, and most of them were from South India, especially the states of Telangana and Andhra Pradesh. So coming to the brief socio-demographic details, so most of them belong to the age group of 21 to 40, come from city, upper middle socio-economic status. Though we got responses from all the professions, majority were students followed by doctors, and almost 50% were there not at all working during the lockdown, and whereas 24% were working from the home and 24% were working outside full-time and part-time. So coming to their mental health status, and 22% were screened to be having depression, 15 with anxiety, 10 with stress, and 27.5 with either of them, which is a very significant number. Coming to our main domains, source of information and knowledge on COVID-19. So major source of information for this study sample was traditional media followed by social media. But surprisingly, only 47% agree that the information that is telecast in traditional media is completely authentic, and it is only 15% for social media. So coming to the impact of time spent on media, so 46% say they spend more time on media and they have statistically significant depression, anxiety, stress when compared to the others. So half of them say that the information which is telecasted on media is only half of it is useful for them, and certain individuals it is creating a panic and they have high scores on that scale. And the most common reason for them to forward this information to others is to educate them others. And 50% of them were restricting the information on COVID-19 on media to avoid fear and panic. So one of the unique findings of our study is almost 61% of the sample felt that many times distressed by using a lot of smartphone during the lockdown. And coming to their predictive and relaxation activities, so one important finding of this study is the individuals who plan their day well and use their day productively had statistically less scores for depression, anxiety, and stress when compared to the individuals who didn't plan and wasted most of the day. So different productive and relaxation activities indulging by the different peoples during this lockdown is physical exercises, enriching knowledge and skills, spending quality of time with the family. So individuals who are indulging in these productive activities have less scores when compared to the others who are not indulging in these things. And coming to a few general views of lockdown, so almost 46% felt that they were suffering and difficult to manage, and they have statistically significant scores on that. So, and 46% were not completely confident on medical system that it would treat them. And though 96% of the individuals are okay and they accept the lockdown is the correct decisions, but only 58% are completely satisfied with the government measures they are taken. So this clearly indicates that more the level of satisfaction with the measures taken by the government, the better is the mental well-being. So that is the important point. Because again, this government measures impact was taken to the people by the media. And 96% know they opine that media plays a crucial role in this. So summary of the correlation analysis. So this just I want to summary, like more the time they spent on media and smartphone, the higher are the scores. And more productively they use, the lesser are the scores. So coming to my discussion, so the percentages which we see in our study are little less when compared to that of China and Italy, which were done in January and March, because those were the first countries that were affected badly, and uncertainty of the mode of transmission by the WHO. These are the few reasons why they have little more scores when compared to our study here. And significant finding of this study is most of them, almost 60%, they just say that the information that is telecasted on media is not authentic. There are many reasons for that. So you can observe like during lockdown time, there is a high amount of information that is scrolling on the media, and there is a word for that, that's not an infodemic. Even WHO itself has declared that we are not fighting epidemic, also social media infodemic. Because of this huge volume of the information, there is every chance that the fake and misinformation can be telecasted, and there are studies on that misinformation has been telecasted during the lockdown time. And there are different types of misinformation from cultural, prevention aspect, casualty, economy, government statistics are also misinformation. So because of this misinformation, it could definitely impact the mental well-being. It is significant in our study that more people, they spend more time on the media, definitely they have more scores on the DAS. So here interesting finding is 15% say that information that is telecasted in social media is authentic. But irrespective of authenticity, 72% forward this information to others. Because of that, it is creating panic in certain section of individuals. And our studies are similar to the studies from China and Ahmed. So finally, what I would like to say is traditional media need to introspect and filter authentically the information they telecast, because that is the only major source in the situations like pandemic. And at individual level, we all need to feel responsible and selectively forward the information.
spike in internet use during that particular periods of lockdown. So even we all use smartphone excessively for various purposes like educational, information purpose, but any excess use always causes distress. It is clearly evident in our study. So the smart use of smartphone improves the psychological resilience of an individual. So, and once again we proved the hypothesis that more the planning and more productively we use, the better. And even today morning sessions of yoga and family relationships clearly said that the more quality of times we spend with the family, more physical exercise we do, and more music and entertainment activities, more relaxed we are, more psychological resilience we have. This message needs to be propagated widely. So even now, this government measures, the level of satisfaction is more, so the better mental well-being. And this government measures, whatever they are doing, it is taken away by media. So what we conclude is the authorities need to ensure adequate measures are taken at appropriate time. And most important thing is they need to communicate to the people on a regular basis, authentically, that too, with the help of a media. And media, no, they have to telecast government information rather than sensationalizing it, creating more panic. So these are the few important conclusions. Even our study have few limitations, like we circulated only in 2 languages, only educated for people and who can use smartphone. They utilize this particular study, but always the online better direct will be better than the online studies. These are few limitations of our study. So finally I conclude saying that, so 1/4 of a sample have mental health issues, and this study could highlight many negative and positive predictors from impact of media and time management perspective. The lockdown is over, but pandemic is not yet. There is a long run. So we have extended periods of last one conclusion sentence. So because like now there may be in future extended period of lockdowns and isolation period. So we need to carry on this message for the better mental well-being of a society in ongoing fight with COVID-19. Thank you very much. So these are my references. So I'd like to take any questions. Sir Keshwara, sir, this is one of our limitations, sir. Just we tried for adequate snowballing effect of the sample, but it's a wide audience because of the lockdown, sir. This is also because of the lockdown that we couldn't communicate with many people. So since we are the doctor society, we have more of doctors community. So far this we could impact, and definitely this is a limitation for our study, sir. It couldn't reflect the entire country statistics and mental well-being, especially the individuals with low socioeconomic status.
Check 1 2. Mic test. 1 2 3. Check.
Hello.
Sir.
So your study is about impact of media
Yes.
on the well-being
Yes.
during COVID-19 times.
Yes.
So you said that you have divided the population according to the usage of smartphone.
Sir.
You have divided the population, your study population, according to the number of hours of usage of smartphone.
Yes.
Right. So you did not consider about the content of what they are watching.
So actually we have done that, but given time, I couldn't project it everything here, sir, in the 8 minutes of a time. So they are informational,
educational related things, and more of as students, they spend more time on games and some pornography also. And these individuals have statistically more scores for depression, anxiety, and stress. Especially, we have 300 students in our study sample, whereas in elderly sample, they spend more time on like news. So, and social media, news, whatever from the other different corners. Engage group, more they spend on games and addiction and movies, and they have more score actually. But because of the lack of the time, we couldn't microly divide it and present that
It would have
particular
been more
thing, sir.
useful.
Yes.
If we compare the content of what they are seeing
Yes,
on
sir.
the cell
I
phone
agree, sir. I
and
agree.
to the
Yes.
present social
Yes.
scenario.
Thank you, sir. Thank you.
To conclude, what is your take-home message
So
from
my
the study?
take-home message is like, no, sir. So we all know that no more the time we spend on media and more productive we use, the latter is less is a mental well-being. But the implementation part is very poor, sir. Even myself, no, I just during that particular period of lockdown, I forwarded many messages without clearly checking the authenticity. So this can impact the mental well-being. That's a basic idea. I got it because of that particular thing. So what I conclude saying is, at least hereafter on this fight with the COVID-19, we need to productively utilize the time when instead of more thinking about what are the things and more rely on the authentic information from a media rather than different news channels, so that it improves our mental well-being. So this message need to be conveyed widely with the help of the authorities.
Okay.
Sir.
So your finding is depression is more common.
Sir?
Depression is more common.
Yes, sir. Depression is more common.
So is it due to the impact of media or the impact of COVID?
So actually, we when compared to the studies which are done in China and Italy, stress and anxiety is more common, sir. And we are the next to be affected.
Stress and anxiety is more common due to COVID. COVID or media?
COVID lockdown and that.
Yeah, COVID lockdown, okay. Because it is COVID as such, or it is because of impact of media?
Both together, sir. And media may amplify the risk, amplify the perception of the risk.
How will you differentiate?
So it is very difficult, sir, because like no more time they spend excessively on. See, COVID is common for everybody, sir.
Okay.
But more time they spend excessively on media, they have statistically significant more scores.
You concentrated more on the impact of media.
Yes, sir.
So your study is restricted to that only.
Yes, sir. Because all are experiencing COVID, but more the individual they spend more time on media, they have statistically significant more scores, sir. Almost all age groups, sir. We have telecasted.
Who uses smartphones only or news channels? Who
Sir?
use smartphones only?
Yes, sir. That is our one of the limitation.
Only smartphones.
Yes, sir. But we circulated it in Telugu, English language also, sir. So, but only the individuals who can use smartphone, that is one of the limitation of our study. Because during the lockdown time, we don't have any other option, sir. So because everybody is everything is paralyzed. We cannot communicate with other, in that particular 68 days, the smartphone is the only method to communicate with the people. Sir? No much sex difference, sir. No. Yes. Slight more in male, but statistical significance we couldn't get, sir.
One more thing is,
Sir.
suppose any past history of any mental illnesses like
Yeah.
depression, anxiety, they're
Yeah.
more prone for this disease.
Yes.
Is it any?
Yes, sir. That is taken into consideration, sir. But we have, in that particular, this particular part, I couldn't present that particular thing, sir, because we have taken into consideration, sir.
Family history and past history.
Past history of medical illness, psychiatric illness, even the behavior changes like hypochondriasis, excessive contamination, social contagion, those aspects also we have considered, but I couldn't present all the things here, sir. Sir? Yes, sir. More the individual, like now, they are, say, past history of psychiatric illness, they have more hypochondriasis, they have more excessive fear of contamination, so they have statistically more scores also, sir. Yes, sir. Yes, sir. Yes, sir. So that perspective also one of the question we have added, but only 8% have past psychiatric illness, sir. So in that 8%, 6-7% almost they said that they could get medicine. from online, something like that, sir. 1 or 2%, because this is again the person who can use smartphone. The person who is, most of them are belong to upper middle classes. So they can easily have their resources or sources to get this medicine. So more we have gone to the low socioeconomic status, then we would have reflected this exact thing, whether the availability of medicine impacted mental well-being or not.
Okay, Dr. Vishwa. If there are no further questions, chat, someone. Why you did not study the time management in terms of other useful activities apart from usage of smartphones and news? This is from Dr. Gauri Devi.
So we have studied, ma'am. Can you show that slide, please? Can you show that slide? So can you roll on the slides? Roll on the slides fast. Next, back, fast, back. Next. This. And next slide also. So these are the different activities. So, ma'am, we have taken 7 activities. Apart from that, we also included in the questionnaire like other relaxation and productive activities as well, ma'am. So we screen the individuals from this perspective also.
What, Vishwa?
Sir?
Have you explained?
Yes, sir. So this slide, I think madam missed, sir. So actually we evaluated from this perspective also.
If there are no further questions, I thank you, Vishwa.
Sir, thank you, sir. Thank you very much.
Now I request the second presenter, Dr. Naveen Kumar, to come and present the paper. 8 minutes for the presentation and 2 minutes for discussion, please.
PM. PM.
Fine. Thank you.
Hello. Sanitizer. Hello. Myself is Dr. Naveen, Associate Professor in ESI Medical College. My title of study, why phenylene malate is so popular among the opioid injecting drug users. This study is abuse liability paradigm study. So double blind randomized experimental design I have used. So coming to the introduction, so recent magnitude of substance use has depicted that 85 lakh people are having of using injecting drug use in the country. So it's a huge magnitude is there. So majority of the people in their different drug of choices, they admix the phenylene malate as one of the common dissolvent. So, and the people that change the opioids usually from smoking and changing route to injecting route. They are for the various reasons like a cost effectiveness of the drug and as well as to increase the effect of the primary drug. So they admix with the phenylene malate and various other dissolvents are popular in the country as a benzodiazepine, like diazepam, and sedatives, promethazine, and apart from that, antihistamines. As the most popular is the phenylene malate. In South Asia and even India too, also having noted that literature has suggested that phenylene malate is quite popular in the state. among the injecting drug users. So the reasons are very varied. So common reasons are they reported is as a sedation properties, and as well as while they inject the opioids, they produce the opioid related effects like a tingling sensation and itching sensation over the face and other perioral areas. So diminishing those, dampening the those effects, they use the antihistaminic, this
Good afternoon, one and all. So without much ado, let's proceed to the next session. That is Dr. Anand, IMH Hyderabad Alumni PG Poster Award. I call upon the stage Dr. Shirisha ma'am, Professor IMH, for sharing the session. Over to you, ma'am.
Thank you, Dr. Uma Maheshwari. Now we'll go on to award poster session. The name of the award poster is Dr. Anand IMH Alumni Poster Award. So we have 2 entries for this category. And first presenter will be called upon to the stage. They will be given 5 minutes for presentation, followed by 5 minutes discussion. Are you guys ready with time? Fine. First presenter I am going to call Dr. Aditya Kashyap. Title is A Case of Gratification Disorder Simulating Epilepsy. He is studying MD 3rd year, IMH Institute.
Award poster. Good afternoon, everybody. I'm Dr. Aditya Kashyap, final year postgraduate at IMH. Today, my case is a case of gratification disorder simulating epilepsy. So coming to the introduction, gratification disorder, also known as infantile masturbation syndrome, is a form of masturbatory behavior that is often mistaken for epilepsy, abdominal pain, paroxysmal dyskinesia. The term disorder seems as a misnomer, as it is a normal behavioral variant seen in early childhood, starting from 3 months to 3 years of age. In spite of having case reports in Western literature, there's little or no reports in Indian literature, which may be due to the stigma related to such behaviors. Coming to the case details, we present a 1.5-year-old male child was brought by his parents to the Department of Pediatrics for abnormal movement episodes lasting around 1 to 3 minutes, occurring multiple times in a day for 2 months. The episodes had begun when the child was 16 months of age and were described as lying down with tonic posturing of upper body bending backward with cyclical movements and also scissoring of lower limbs with grunting-like sounds. During this episode, the child is fully awake, responds to call during episodes, and also sometimes stops the movement on slight force over lower limbs. Post-episode, the child looks tired and occasionally goes to sleep. No bladder or bowel incontinence during the episode were noticed. No episodes were seen during sleep. The child was born to non-consanguineous marriage, second in birth order, and was delivered at term with no significant abnormalities, complications, or no history of developmental delay. Mother did not report any history of sexual abuse either. Due to this, the child was taken to a local pediatrician for assessment of such episodes. Though the results of hematological, radiological investigations and EEG were found to be normal, the child was started on anticonvulsants, assuming the condition to be a variant of seizure disorder. On follow-up, the child did not show any response nor improvement in episodes. So he was referred to Department of Pediatrics at Nilofer Hospital, where he was reassessed. In view of the negative results of the investigation and suspecting behavioral issues, the child was sent to Department of Child Psychiatry for further evaluation. Detailed history was taken and the parents were advised to do a video recording of the episodes. There was no family history of seizures nor movement disorders. The history and the video recording was consistent with diagnosis of gratification behavior. Infantile masturbation syndrome, which is also called childhood gratification disorder, was diagnosed and the mother was reassured, counseled regarding the benign nature of the presentation. She was also advised to distract the child during such episodes and involve him in interactive play. The episodes reduced gradually over a period of 6 months duration of regular follow-up. Coming to the discussion, As such, masturbation is a very common activity and is seen in almost 90% of males and around 60 to 70% of females at one point in their lifetime. Masturbatory behavior in infants and young children is difficult to identify because it is often does not involve manual stimulation of the genitalia. The typical clinical features include onset at age greater than 3 months and less than 3 years, stereotyped episodes of variable duration, vocalizations with quiet grunting, facial flushing with diaphoresis, pressure on the perineum with characteristic posturing of the lower limbs, no alteration of consciousness, cessation with distraction, and normal examination and investigation findings. The video recording of these episodes is invaluable in the diagnosis of such disorder behavior because parents may use the wrong descriptive terminology while describing such postures. Treatment usually involves counseling and educating the parents that it's a normal behavioral variant in children and that they will often outgrow it. They are also encouraged to distract the child by involving him in various activities. Also, the child must be involved in other play activities which could redirect the attention from masturbatory activities. Such similar case reports were reported in girls also by various authors, as mentioned in my references. Coming to the conclusion, gratification behavior is a normal behavioral variant in children and often subsides over time as age increases, and clinicians should be aware of its existence. Otherwise, it could be misdiagnosed as seizure or any movement disorder and may warrant unnecessary battery of investigations and treatment. Thank you.
Dr. Aditya has finished his poster presentation. Now it is open for discussion. Can I have the charts, please? Are we connected? So now questions will appear on charts. I will read out the question. You will have to respond, Dr. Aditya.
Yes.
Any questions from audience? Any questions from audience? What mic you have? Yeah, please.
How common is this condition? Is it a common condition?
Sir, this is a normal behavioral variant. Commonality, I mean, the number of reporting the cases has been less, so we don't know the prevalence or the incidence of such behaviors. This is a normal presentation, but it's rarely reported. So I wanted to present this case.
Yeah, there is one more question, Dr. Aditya, would like to take. Do you consider it as any of neurotic symptoms of childhood?
No, ma'am. It does not come under neurotic symptoms of childhood because he was assessed by the psychiatrist. It was it was sudden in onset without any precipitating factors or anything, and it was to be subsided when the child was distracted and all. So it does not come under any. It was not having any precipitating factors as such.
Why I think this question was asked, that is my understanding, I am telling you. They are asking whether can it be a neurotic symptom, because you have called it as a gratification disorder. If it has to be disorder, means it has to cause some amount of impairment, some amount of disturbance, some amount of, does it call, is it meeting the criteria so that you can call it as a disorder?
Yeah.
Or is it a normal variant?
Yes, madam. As I clearly mentioned, the term disorder, the term given to such behavior, it was mentioned as gratification disorder. But I mentioned that the term disorder itself is a misnomer because it is again a normal behavioral variant.
One more question coming up. Was EEG done in this case and what were findings?
EEG was done in this case twice by the local pediatrician, and again when the child was followed up in Nilofer Hospital, it was having normal findings of EEG. It did not report any seizure activity or abnormal electrical activity in the reports.
So next question by Dr. Lokeshwar Reddy Pabbati. He is asking, what should have been done if the child was seen by the psychiatrist? What should have been done if the child was seen by the psychiatrist first?
Generally, such cases don't go to a psychiatrist first. That's what happened in this case also. The child initially went to a pediatrician, and then it was because the pediatrician couldn't manage the condition, it was referred to a tertiary hospital at Nilofer, and then the pediatrics department referred it to neurology. They also suspecting it to be some abnormal seizure activity and all. So it's very unusual to see this case to be presented for initial to a psychiatrist. The main reason to present this case was to throw some light to the budding psychiatrists like us to know that there is existence of such conditions.
Then one more question from Gauri Devi Madam. Madam is asking, is there lack of stimulation from parents? You need to look from home atmosphere. Madam is telling she has seen 5 cases where there is excess or lack of stimulation.
Yes, madam. So
is there anything like that in that case?
In the literature which I've gone through, madam, such cases don't know, there's no exact mechanism of how this disease appears, but there have been reports which says lack of stimulation, lack of excitement, lack of stimulation, boredom, and low self-esteem have been considered as to be the reasons for such behavior. And they'll again, over time, they'll just outgrow it.
Yeah, one more question from Dr. Shanti Mohan. He is asking, was video EEG done in this case? As the sensitivity of regular EEG is only 60% in this case, in such cases. Was video EEG done?
Video EEG was not done, it was just regular EEG.
Okay, then that is something where you have missed. Okay, next question is, what could be the possible reason or hypothesis for such reasons, as you mentioned, that no precipitating causes could be found?
I didn't understand.
What could be possible reason for hypothesis for such reasons?
I didn't get the
Why
question.
such behavior is occurring, this gratification disorder? What could be the hypothesis behind such behavior? Maybe
There is no definite cause for such behavior, ma'am. As Gauri Devi ma'am also mentioned, like lack of stimulation and the home atmosphere might be one of the conditions which might have resulted in such behavior. So it's more like distraction and giving proper attention to the child might help.
Your time is up. Thank you.
Thank you, ma'am. Thank you.
Can we have next participant? Next participant is Dr. Harish, and his poster presentation is title is Risperidone induced urinary retention in a young male patient.
Hello. Yeah. Good afternoon, respected dignitaries, offline and online, and a warm welcome to Tspsycon 2020. Myself, Dr. Pinoj Harish, Psychiatry PG, Institute of Mental Health, Usmania Medical College. Today, I am here by reporting a case of risperidone-induced urinary retention in a young male patient. Urinary retention is a very painful condition. It occurs most commonly in elderly age groups, that because of benign prostate enlargement, but it may occur as a side effect of conventional antipsychotic treatment, rarely with atypical antipsychotic medications, and other drugs like antidepressants, anticholinergics, anesthetics, benzodiazepines, calcium channel blockers, and NSAIDs can also have been reported to produce drug-induced urinary retention. These urinary problems may be due to anticholinergic side effects or as a form of extrapyramidal side effects. So I'm reporting a case of 30-year-old unmarried male patient, case of bipolar affective disorder, mania with psychotic symptoms, multiple episodes, step-lived on tablet lithium carbonate and tablet olanzapine for past 5 years with no family history of mental illness, no history of substance abuse in patient. And her latest episode in July 2019, for which he was changed from olanzapine to risperidone, as he was found to have metabolic syndrome. This episode, he was treated with lithium carbonate and started with risperidone 6 mg and increased to 8 mg to 12 mg over a period of 1 week. And after reaching to 12 mg, patient developed acute urinary retention and constipation. And the reason for increase to risperidone was as there was no clinical improvement. And lithium was also increased to 1200 mg. And there was no history of any urinary problems in the past. And there was no history of fever and burning micturition.
And he was sent for urologist consultation. They did ultrasound and complete urinary examination and urodynamic studies, and we sent for serum lithium levels and complete blood picture and all. That ultrasound shown grade 1 prostatomegaly, and urine examiner shown 2 to 3 pustules in urine, and advised antibiotic for 5 days. And his renal function tests and serum lithium levels were found to be normal. His urodynamic studies revealed acontractile detrusor, and even after completion of the antibiotic course, patient's condition did not improve, and constipation was treated with dulcolac. And as patient's condition did not improve, getting worse day by day, patient used to become restless because of that acute urinary retention. We had to catheterize the patient in the morning time, and in the evening time, because of the discomfortness, patient used to insist us to remove the catheter. Otherwise, he used to become restless. So with that, and it was associated with constipation, decided to stop tablet risperidone. So urinary retention improved in a period of 4 days after risperidone was withdrawn. And the patient was discharged with lithium and quetiapine. Patient came for follow-up and maintaining well for past 1 year. So coming to discussion part, as per existing body of literature, urinary problems are most often seen in elderly age group, female gender, and prior urinary pathology and treatment with conventional antipsychotics, where significant risk factors are present. But our case is male gender, young age, lacking family history, present with acute retention, and he developed urinary retention on high doses of risperidone. And no other anticholinergic side effects like dry mouth, tachycardia, anhidrosis, all those things were not found, and only had urinary retention and constipation. And he did not manifest any extrapyramidal side effects. And conventional antipsychotics not only act on D2 receptors, but on cholinergic, histaminergic, adrenergic receptors, and cause variety of side effects like extrapyramidal, sedation, and anticholinergic side effects. Because conventional antipsychotics bind D2 receptors very tightly and with higher affinity, whereas atypical antipsychotics occupy D2 receptors for a shorter duration of time and with low affinity. So when compared to the conventional antipsychotics, so these are bind for shorter time. In our case, patient developed urinary retention with risperidone, which has less D2 binding for shorter duration. The reason for might have been alpha-1 adrenergic receptors are widely distributed over the lower urinary tract, especially smooth muscles of the trigone and detrusor muscles of the bladder. So peripheral alpha-1 adrenergic block and blockage of central dopamine and serotonergic effect may act together to cause urinary retention. These consistent with previous case reports showing haloperidol, olanzapine, risperidone, and aripiprazole have central dopaminergic blockage and agonistic action on alpha-1 receptors causing urinary retention. So I conclude that antipsychotic induced urinary retention due to dopamine 2 antagonist, anticholinergic or peripheral adrenergic action or combination of all of above. Quetiapine may be tried in case patient develops any psychotic effects with quetiapine. Other psychotics, you can try quetiapine. So clinician treating acute urinary retention have to be mindful about atypical antipsychotics can also cause urinary retention, even though it is rare. So pharmacogenomics, it is a branch of study about genome role in drug response, which may help which subgroup of people will develop and will respond to the psychotropics. So these are my references. Thank you.
Yeah. Dr. Harish has finished his poster presentation. Now the session is open for discussion. Can I have charts, please? Any doubt, any clarifications from the...
Sir, yes, sir.
So when the patient was on olanzapine, there was no retention, but later risperidone was added and it has caused that. So what is the rationale? Like, because it has more anticholinergic than this.
Yeah, yes,
and
sir.
Second question is like risperidone along with, because 12 mg of risperidone was there any prophylactic anticholinergic given?
Hello? Oh, yes, ma'am. Yes, sir. Here the patient developed urinary retention on higher doses of risperidone. Initially, he was on 20 mg of olanzapine, sir. Here we started equivalent dose, that 20 mg is risperidone 6 mg. At a dose of 6 mg did not develop any side effects. But when we increase the dose to 12 mg of risperidone, which is more than generally equivalent dose should be more than 30 mg. So at that dose, patient developed risperidone. Maybe if we increase olanzapine to 30 mg or more than that, maybe we don't know about that, sir.
Whether anticholinergic was added or not?
No, sir. Patient was not added any anticholinergic drug.
Whether anticholinergic medication was added?
No, ma'am. Here we did not add any anticholinergic effect. Sorry, I'm not getting those. I'm not getting. Patient was any anticholinergic.
Patient was on risperidone.
Yes, ma'am.
Then did you add any anticholinergic medication or not?
No,
That is
sir.
his question.
No,
Am
sir,
I
we
right,
did not.
Dr. Siva?
Yes, sir, we did not have any anticholinergic effect medication, sir.
Yeah, we have a question from Dr. Shanti Mohan. He is asking, after how much dose of risperidone it acts like a conventional antipsychotic?
Atypical antipsychotics. At higher doses, it acts as conventional antipsychotics. Maybe it is more than 6 mg, 8 mg, it will act as conventional antipsychotics.
One more question we have. Yeah. From Dr. Nisaruddin, was tablet trihexyphenidyl used in this case? Why was risperidone and not lithium or other drugs not suspected to cause urinary retention?
Here, trihexyphenidyl were not added in because of there was no extrapyramidal side effects. And first we thought that lithium might be have causing this renal problems. So we stopped lithium carbonate and we sent for serum lithium levels and renal function test also. Generally, why? Because lithium causes renal damage, but it was found to be normal. And only lithium is on patient.
Then next question is, don't you think starting dose of 6 mg risperidone and increasing to 12 mg within a week is the cause of this side effect? And this is not the usual practice of starting risperidone.
Sorry, ma'am.
Don't you think you have started the patient on risperidone 6 mg and you have increased the dose to 12 mg within 1 week? So you have started little higher dose and you have escalated the dose also quite soon.
Yes, ma'am. Patient
Maybe
was.
is it the reason why patient has developed urinary retention? That he is asking.
Yeah, maybe because we started that equivalent dose of the previous olanzapine. Patient was on olanzapine 20 mg. So we abruptly stopped that olanzapine because of metabolic side effects. So then we directly started with equivalent dose of olanzapine, that is risperidone 6 mg. As patient was very disturbed and there was no clinical improvement, we had to increase the dose to stabilize the patient.
Then another question from Dr. Rajesh, did psychotic symptoms improve with quetiapine?
Yes, sir. Yes, sir.
You stopped risperidone, you put the patient on quetiapine.
Yes, ma'am. Yes, ma'am. After adding quetiapine and we had multiple follow-ups, patient is maintaining well with there is no antipsychotic psychotic symptoms was come down and currently patient is maintaining well. Quetiapine is we are maintaining him on 400 mg, sir.
Any other questions? Sir, Keshav. Another question from Dr. Lokeshwar Reddy. What could be the possible mechanism?
It could be because of anticholinergic effect, first thing. Why? Because because of that anticholinergic effect, it inhibits the parasympathetic system, which blocks the acetylcholine by blocking the muscarinic receptors. So there was a detrusor. In urodynamic studies also it revealed that acontracted detrusor. So that means that acetylcholine is not blocking the, not acting on the muscarinic receptors. So there was contractions were lost. And another possibility mechanism is alpha adrenergic mechanism. So alpha adrenergic receptors are present in internal sphincter. So when it is stimulated, it causes contraction of the internal sphincters. Thus, it could be caused urinary retention.
Thank you. Thank you both presenters.
Thank you.
With this, we end the poster presentation, award poster presentation.
Now I would request Dr. Keshav Rao sir, Consultant Psychiatry, Chaitanya Hospital, Hyderabad, to present the memento to Dr. Sirisha ma'am for chairing both free and award posters and for her coordination in making the conference successful. Now we would take the program ahead with Dr. P.R. Reddy, IMH Alumni Association PG Award, I would request Dr. Naresh Vadlamani sir, Consultant Psychiatrist, Columbus Hospital, to come up on the dais as a chairperson for the same.
Is it time? Can you start? Yeah, right. I'm Dr. Naresh Vadlamani. I'm a consultant psychiatrist and a private practitioner. I thank the Indian Psychiatric Society Telangana State Branch for making me the chairman for this session. It's a prestigious award, PR Reddy IMH Alumni Award. And I thank the organizers, the president, Dr. M. Mayurnath Reddy, the vice president, Dr. Jagannath sir, Minaj, General Secretary, Vishal, the Treasurer, and the editor, Dr. Sai Krishna. They are the office bearers and all the EC members of the Indian Psychiatric Society, Telangana State Branch, for giving me this opportunity to chair this session. Thank you very much. Now, without any delay, I'll just start the session. It's a PR Reddy IMH Alumni Award. The first presenter is Shruti Agnihotri. She's a second year MD student of Institute of Mental Health. The title of the paper is a comparative study of emotional intelligence in individuals with antisocial personality disorder and normal population at a tertiary care center in Hyderabad. The presentation is 8 minutes and 2 minutes for the questions. Without any delay, we'll start.
The title of my study is A Comparative Study of Emotional Intelligence in Individuals with Antisocial Personality Disorder and Normal Population at a Tertiary Care Center in Hyderabad. Slide. It's not working. Yes. And my co-author is Dr. Anita ma'am. Coming to introduction, the term emotional intelligence was first given by Michael Beldock, and it is defined as the ability to monitor one's own and other people's emotion, to discriminate between different emotions and label them appropriately, and to use emotional information to guide thinking and behavior. So the individuals who have higher emotional intelligence, they are less likely to succumb to negative impacts of stressors, and any deficits might lead to a number of adjustment issues, and those individuals may have difficulty in planning an emotionally fulfilled lifestyle. So those individuals who have low emotional intelligence, they are also prone for risky behavior, and they are less empathetic. They have reduced capacity to regulate anger, desire, sexual assault, which arousal, which may result in theft, sexual assault, and other crimes. According to Malloy, an individual who qualifies for diagnosis of ASPD most likely lacks the ability to experience emotions and also other feelings that enables him or her to connect with others emotionally. Coming to review of literature, there have been many studies done on emotional intelligence. And according to Goldman, it is said that Emotional intelligence allows individual to persist in situations in which they encounter barriers to success. According to other study, it was emotional intelligence was said as a person's success-oriented traits. And there are many studies done in medical students and postgraduate students, and it was found that they had good level of emotional intelligence, and it also decreased with the increase in the workload. There are other studies conducted by Mega IM to link emotional intelligence and criminal behavior, which showed that offenders had low level of emotional intelligence. This was supported by many other studies. However, there are no studies, no Indian studies, which were done to assess emotional intelligence in antisocial personality disorder and comparing the same with normal population. Hence, the present study was done. So the aim of the study was to study emotional intelligence in individuals with antisocial personality disorder and compare it with the normal population. Objectives are to evaluate emotional intelligence in individuals with ASPD, in normal individuals, and compare the score of both the groups. Coming to materials and methods, the study was conducted on 35 patients selected from forensic ward at IMH, and the other 35 individuals were selected from the community. After age and gender matching was done, and they were biologically not related to ASPD group, and it was conducted after ethics committee approval was obtained. It is a cross-sectional comparative study done over a period of 3 months at forensic ward in IMH, and the study subjects are ASPD group and normal subjects from the community. For ASPD group, males from forensic ward who were 18 years or more were selected and educated up to 10th standard, or at least they were able to read English, Hindi, diagnosed with ASPD as per ICD-10 criteria, and those who are willing to give informed consent. For normal group, males who were not accused for any crime were selected, and rest of the criteria is the same. For participants with any psychiatric or physical illnesses were excluded. Those who were not cooperative, not able to understand, and those who scored more than 10 on general health questionnaire were also excluded from the study. So my study tools are semi-structured intake proforma, ICD-10 criteria, a general health questionnaire, Mangal emotional intelligence inventory. So after obtaining informed consent, semi-structured interview was done to gather the socio-demographic details and crime details. And after that, general health questionnaire was applied to to quantify the risk of psychiatric disorders, and also Mangal emotional intelligence inventory was used to assess emotional intelligence, and statistical analysis was done using SPSS software. Coming to result and discussion, from this, the data which was gathered from the study has shown following results. We skip coming to the first table. It shows socio-demographic data of both the groups, and in this we can see that coming to occupation group, in ASPD group the number of unemployed were more compared to that of the normal group, and the difference between the two groups was statistically significant with a p-value of 0.027. Other variables also showed some minor differences, but it was not statistically significant. Here's a table which is showing the results obtained from Mangal Emotional Intelligence Inventory. It has 4 subdomains and the aggregate total emotional intelligence score. As we can see, the ASPD group scored less on this when compared to normal group, and the p-value here is 0.00. So from the results, it can be said that criminals had a total emotional intelligence score of 33.5 with a standard deviation of 1.8, which falls in the category of poor emotional intelligence, whereas the normal population had higher score, which falls in the category of good emotional intelligence. So the mean score was compared and it was statistically significant. This was also supported by previous studies which showed that offenders had lower levels of emotional intelligence than non-offenders. And also it varied with the type of offenses done. Criminal thinking and criminal styles also was negatively correlated with emotional intelligence. However, there was only one study done in India which says that emotional intelligence score of criminals was also good. So therefore, it can be implicated that antisocial disorder individuals have poor control over their emotions. They cannot appreciate others' emotions. There's poor management of own emotions, and also they cannot understand or manage others' emotion, therefore resulting in aggression towards other. Impulsivity, problem solving, and social skills were some of the important domains which were tested in the study, and it was impaired in the antisocial group. Here's a table which is showing a relationship between number of crimes and total emotional intelligence score. As we can see, the p-value is significant and the Pearson correlation gives a negative value. So it means that the negative value indicates that there is an inverse relationship between number of crimes and the emotional intelligence score. So more the number of crimes, less is the emotional intelligence score in them. This was supported by previous studies as well, which says that emotional intelligence have a complex pattern of interrelationship with the criminal behavior. There were other studies conducted to assess emotional intelligence. This shows crime details. Conclusion is the offenders with antisocial personality, they had lower emotional intelligence, so there's a difficulty in dealing with their emotions, and also inverse relationship between number of crimes and emotional intelligence. Strength is that there were no studies done on ASPD population. Limitations are no females were included, and the sample size was also small. Emotional intelligence enhancement programs can be done to improve the emotional intelligence among prisoners, so that will improve their quality of life and might also decrease the future crimes.
Yeah, okay. Anyone from the audience have any questions? Yes, Dr. Shivakumar.
What are findings you had, like impulsivity, lack of remorse, and all these things are a part of it. No? What is that you are going to show by this? What is that? It's a known fact. Like you have low emotional intelligence, and what are the findings you found correlating with the same thing? What is that research or the question? What is that implication? What we are going to get?
Implication is that, sir, there were no studies done on the antisocial personality group to check their emotional intelligence level. So if we can, so there were no studies done in the antisocial group, sir, in Indian context. So if we calculate the level of emotional intelligence they have, we can use some emotional enhancement programs. It is not that all the antisocial will have a low emotional intelligence score. There were some one or two studies which showed that they had good emotional intelligence. But in my study, I found that all of them had poor.
Usually it is a scenario.
Yes, usually, but not all of them.
So one more question from the audience. What was the sample size?
Total sample size was 70, 35 from ASPD group and 35 from normal community.
The second question. Did you use any screening instrument for determining normalcy? How did you screen the normal population for any other personality disorders?
I did not use any screening instrument for determining the normalcy. Normalcy, no.
Right. Can emotional intelligence help us intervene therapeutically?
Yes, we can. There are techniques to enhance emotional intelligence. Intelligence can be enhanced, and it will help the individual to appreciate others' emotions and also manage your own emotions.
ASPD cases had any comorbid psychosis? Is the control group well matched and with education and socioeconomic status? Are they repeated offenders?
All the psychiatric, in the exclusion criteria I mentioned, all psychiatric and physical illnesses were excluded. And there was only gender matching was done. So that could be a limitation of the study. I did not do socioeconomic status.
Thank you very much. That's the end of the question session, the first one. Right. The second paper is by Dr. Divya Meghna. She's a second year MD student from Institute of Mental Health. A study of pathway of care among persons with mental illness attending a tertiary care center in Hyderabad.
Good afternoon, everyone. The title of my study is A Study of Pathway of Care Among Persons with Mental Illness, attending a tertiary care center in Hyderabad. Coming to the introduction, mental illnesses are commonly associated with higher disability and burden than many physical illnesses. They are often accompanied by lack of awareness and social stigma, which leads patients and their families to seek alternative service providers. There are other reasons like non-availability of mental health professionals, superstitions, and unwillingness or inability of family members to take care of persons with mental illnesses. So the study is conducted to study the delay in duration and reasons, different places where help was taken before attending first psychiatric consultation among patients attending psychiatric OPD of tertiary care hospital. If we see the review of literature, the literature says that most common reasons for delay in psychiatric consultation were ignorance about the illness, followed by belief in magical and religious methods, stigma towards psychiatric illnesses, patient refusal, financial problems, and caregivers' education. In a study done by Lahari et al. In 2010, it showed that 69% have contacted faith healers as first contact for their illness, and only 9.2% have contacted qualified psychiatrists at first instance. In a study done by Mishra et al. In 2011, it showed that 45% of study population have accessed non-psychiatric physicians and faith healers as first contact for their mental illnesses. So studying these pathways is a quick and feasible method of studying the help-seeking behaviors of people with mental illnesses and their families. So it helps us to create awareness in population for better outcome and prognosis and for effective referral mechanism from non-psychiatric physicians. The aim of my study is to assess pathway of care among persons with mental illness attending a tertiary care center, and the objectives are to study the delay in duration for first psychiatric consultation, to study the reasons for delay in first psychiatric consultation, and to study if there is any association between socio-demographic factors and illness variables and delay in first psychiatric consultation. So basically, this is a cross-sectional study conducted at Institute of Mental Health, Hyderabad. We have collected 250 samples by simple random sampling method over a period of 3 months. We have included patients who are attending to our hospital for the first time, and all psychiatric diagnoses were considered. Patients who are with reliable informants and who are able to consent for participation of study were included. And obviously, we have excluded patients who have not given consent for the study and who are not having reliable informant. So we have considered relatives or family members who have been in contact with patient ever since he or she developed mental illness, who doesn't have any psychiatric illness, as reliable informant for our study. So after considering the inclusion and exclusion criteria, patients are taken into the study by simple random sampling method, and the purpose and objectives of study are explained to patients and their informants in a language which they can understand. After obtaining informed consent from the patient and they are entered into semi-structured intake proforma consisting of socio-demographic details, diagnosis as per IC-10, duration of delay, and reasons for delay in psychiatric consultation. So the study tools we have used are semi-structured intake proforma and International Classification of Diseases 10th edition. So this is the intake proforma containing socio-demographic details and disease variables. All the data that is obtained was statistically analyzed accordingly to interpret the aims and objectives. Chi-square test was done to compare the clinical characteristics, and a p-value of less than 0.05 was taken as significant. Data was analyzed using SPSS version 22. Coming to the results, it was found that majority of the study population were males, literates, and unemployed people, and majority of them belonged to 20 to 40 years of age group, low socioeconomic age group, and married population. It was also found that majority of the our study population belonged to had 1 to 5 years of duration of illness, and they had a diagnosis of schizophrenia-related disorders, and majority of them had contacted faith healer as first contact for their illness. There was a statistically significant association between age, gender, literacy, employment, income, and first contact. So it was found that majority of the population who had contacted faith healer as first contact belonged to 20 to 40 years of age group. Majority of them were females, illiterates, unemployed, and low socioeconomic subjects. Also, there was a statistically significant association between diagnosis and first contact. Majority of the subjects who had made their first contact with faith healer had a diagnosis of schizophrenia-related disorders. And it was also found that 71 out of 250 population of a study population, they haven't taken any professional help before coming to our hospital. If we discuss these results, the reason for having more than 66% of population in the group of 20 to 40 years of age and male preponderance, which is in line with the study done by Lokesh et al. This could be the academically productive age group and breadwinners of the family, and so any turbulence in their health will affect family functioning and might have brought earlier. And the reason for majority of being literates may be due to better comprehension of illness, need for treatment, and approach psychiatric care. And we have also had 65.2% of unemployed population and 75.2% of low socioeconomic status population. And the reason could be because the sample is taken from a government hospital which caters to people of low socioeconomic status and below poverty line. And we also had majority of the population of married subjects, and the reason could be because the availability of caregiving person in married population. In the present study, there were more subjects of schizophrenia spectrum disorders, and this may be due to disorganized behavior, disruption of daily activities, and might have prompted early consultation by schizophrenia and mood disorders patient than anxiety disorders. And there's an important finding that 35.2% of the patients have consulted faith healers as first contact of care, and 19.6% have not taken any treatment from any facility before coming to IMH. So taken together, more than 50% of sample have not taken any professional help for their problems. This is in line with the Lahari et al. Study. Patients, this could be because patients, because of their ignorance or stigma about the psychiatric illness, might have taken faith healers' help. On an average, the duration of untreated illness of a sample is 5.81 years, which is the delay in duration of first contact. This is a pie diagram showing reasons given by informants for not taking early psychiatric consultation. The most common reason being financial problems and ignorance about the illness, both of them constituting more than 50% of the reasons. So there are certain limitations for my study, which is a component of recall bias and size of the sample, which limits generalization of results, and our study is from a single center. So to conclude, majority of patients have been found to follow indirect pathway of psychiatric care approaching faith healers, alternative systems of medicine, general practitioners, and finally psychiatrists. Only 19.6% of patients consulted psychiatrists as first contact of care in our study. Financial problems and ignorance about illness being predominant causes for delay in psychiatric consultation.
1 minute.
Thank you.
So that's very good that you have finished well in time. So any questions from the audience or from? No, I have one question.
So,
what extra is your study generating to the existing literature?
Sir,
compared to previous studies, is there something
Yes, sir.
extra that your study is contributing?
Sir, we have studied the average duration of delay in first contact of psychiatric consultation, sir. That is 5.81 years. The literature which I have gone through, they haven't mentioned this average duration of untreated illness.
Right. Okay. Yeah, we'll go for the. Can you? Is there any significance between rural and urban population?
That factor we did not assess, sir. Rural and urban population.
Where both sexes assessed, was there any differences between the sexes?
Yes, sir. There is a difference between sexes. There is male preponderance in our study population.
Right. Did patients approach Ayush disciplines according to your study?
Yes. Yes, sir. Patients have approached Ayush, homeopathy doctors. They are, I have categorized all of them under general practitioners.
Right. Okay. Keeping your findings in view, should we develop more centers of excellence, not in reach of rural and uneducated population, or more psychiatric care at their doorsteps? Dr. N.G. Sanjay Kumar.
Yes, sir. There is a dire need of spreading the psychiatric facilities in rural, distant populations also, distant groups of areas also.
Right.
Because one of the factor being distance of travel also, more distance of travel also, patients are not able to receive proper care.
Right. So last question. How many had first contacted non-psychiatric physicians? What was the average duration of delay from them to a psychiatrist?
Non-psychiatric physicians.
General physicians.
Yes, sir.
Non-psychiatrists, from there to psychiatrist. What was the?
That average duration I did not study, sir.
Okay, that's fine. Thank you very much.
Thank you, sir.
So we'll go for the third paper. Dr. Sanchita Gaur, second year MD student, Institute of Mental Health. A cross-sectional study of intimate partner violence, adverse childhood experiences and psychiatric morbidity in females with mental illness at a tertiary hospital in Hyderabad.
Good afternoon, everyone. I'm Dr. Sanchita Gaur, second year postgraduate from IMH Hyderabad. My co-author is Dr. Sirisha ma'am. The topic of my presentation is a cross-sectional study of intimate partner violence, adverse childhood experiences and psychiatric morbidity in females with mental illness at the tertiary hospital in Hyderabad. Coming to the introduction of the study, intimate partner violence is a big public health and social problem across both developed and developing countries. It includes physical, sexual, emotional abuse and controlling behaviors causing harm by an intimate partner. It is any behavior within an intimate relationship, whether married, unmarried, or in a live-in relationship. Several factors are known to increase the risk of IPV among women in the hand of their partners. These include individual factors like young age, low education, witnessing, experiencing violence as a child, relationship factors like marital conflict and instability, dominance and control by one partner, community factors like poverty, high unemployment, high alcohol intake, societal factors like gender inequality, traditional gender norms, weak economic laws, and cultural norms that support aggression. Consequences include denial of fundamental human rights and undermining of development goals. Health consequences like high level of depression, anxiety, phobia, suicide risk, alcohol and drug abuse, physical inactivity, PTSD, self-harm, unsafe sexual behavior, high incidence of stress and functional disorders, impact on children. Children who witness violence become victims and perpetrators when they grow up. Socioeconomic costs of violence. Coming to the review of literature, longitudinal studies on domestic violence have found a bidirectional relationship between IPV and psychiatric morbidity. According to a study done by Miriam K., adolescents with psychiatric disorders were more likely to get involved in abusive relationships and vice versa. Indian studies have found variable prevalence of IPV among females depending on the setting, 16% in community sample, 50% in urban health centers, 56% in rescue homes. Psychiatric morbidity was 58% had depression and 12% had PTSD. The socio-demographic correlates associated with increased risk of IPV were alcohol use among partner, family history of domestic violence, aggressive partner, unequal income and education among partners. Increased age of marriage and support from illness was found to be protective against IPV according to various Indian studies. Early adverse childhood experiences, current life stress, low income of partners correlated with IPV among partners. Coming to the aim of the study, it is to assess the proportion of intimate partner violence, adverse childhood experiences, and psychiatric morbidity in females with mental illness. Objectives of the study is to estimate the proportion of IPV against female subjects in remission by intimate partners, to assess the association between IPV and psychiatric disorders and socio-demographic factors, whether there is any association between adverse childhood experiences and the risk of IPV. Materials and methods, study design was cross-sectional, convenient sampling technique was used. Inclusion criteria is females in the age group of 18 to 45 years in remission stage who consented, married, divorced, live-in relationship or separated, and those who compulsorily have a family member as attended. Exclusion criteria is those with epilepsy, mental retardation, significant head injury, delirium or agitated state. Sample size was 70, duration of study is 2 months, and place of study is Institute of Mental Health, Hyderabad. Coming to the methodology, Institutional Ethics Committee approval was obtained before carrying out the study. Written informed consent was obtained. Remitted subjects were taken up for the study. Abuse assessment screen was applied. Those who answered yes for one question were considered positive for IPV. Similarly, subjects who gave no as a response for all 5 questions were considered negative for IPV. Both groups were required to answer questions pertaining to their socio-demographic, educational, and personal details as part of the intake pro forma. Diagnosis was made according to ICD-10 criteria. The adverse childhood experiences scale was applied to both these groups and statistical analysis was done. Coming to the results, a total of 70 female subjects participated in our study, out of which 47, that is 67.14, experienced intimate partner violence. Majority, 80%, were in the age group of 14 to 24 years. 48.6% of them were unemployed. 31.4 were educated up to school. The mean age at marriage was 22.46 years. 68% of study subjects belonged to low socioeconomic status. 48.57% were married. This is just a table showing IPV and diagnosis. The most common diagnosis that we found to be associated with IPV was schizophrenia. And in those without IPV, we found OCD and alcohol dependence syndrome. A statistically significant association was found between IPV and marital status. A statistically significant association was found between IPV and number of suicide attempts. That is a chi-square value of 0.005. Partners of study subjects who were addicted to alcohol were more likely to inflict IPV. 77% of those who suffered from IPV had partners who were dependent on alcohol. This table shows a positive correlation between adverse childhood experiences and family history of substance abuse. A positive correlation was also found between adverse childhood experiences and number of suicide attempts. A positive correlation was found between adverse childhood experiences and IPV. Coming to the discussion, lifetime prevalence of IPV was found as per our study to be 67.14%. Our study found a higher prevalence as it was done on psychiatric patients at a tertiary care center, hailing from both rural and urban background. The most recent Indian survey, NFHS-4, released in December 2019, on women of Telangana found 42.7% had experienced physical violence by current and former spouses. Of all the socio-demographic factors, statistically significant association between marital status and IPV was found. Our study showed that being married or involved in formal marriage had a protective effect. IPV was more prevalent among schizophrenic subjects. It is quite possible that schizophrenic patients, in view of their illness, may be behaving abnormally, and partners might justify inflicting violence as a means to control them. A study also found statistically significant correlation between IPV and personality traits like borderline and histrionic. Adverse childhood experiences and IPV, a positive correlation was found that is present of adverse childhood experiences increase the risk of IPV. Female subjects who experienced adverse childhood experiences were more likely to place themselves in vulnerable positions and allow their partners to abuse them. Among these adverse experiences, being brought up in a background where domestic violence was highly prevalent, study subjects might have thought their partners abusing them is justified. Our study found a significant correlation between adverse childhood experiences and psychological problems like personality issues and suicide attempts. Coming to the conclusion, proportion of IPV was 67.14%. It was more among subjects who were unmarried, single, divorced, who had borderline and histrionic personality traits. IPV showed a positive correlation with adverse childhood experiences. Study subjects who faced more adverse experiences showed positive correlation with the family history of substance abuse, suicide attempts, and histrionic and borderline personality traits. Implications, we found that borderline and histrionic personality traits, several mental disorders, were associated with increased risk of IPV. Prevention and intervention programs should be directed towards assessment and treatment of IPV among individuals with psychiatric disorders, marital counseling, early diagnosis, and management. To reduce IPV against women, modifiable risk factors need to be addressed.
Time up.
Okay, so these are the drawbacks of the study. That's the intake performance scales, and these are my references. Thank you.
Now we'll go for the questions. Anyone from the audience? Okay, we'll start from here then. Yes, Dr. Keshara sir wants to ask the question.
The connection between adverse childhood effects and this partner violence, is it more because of sociological background? They come from kind of background which are not very conducive, or is it because of psychological? The person is subjected to childhood adverse
Themselves in multiple positions and allow their partners to abuse them.
Their behavior is responsible for that behavior from the partner. Is it more social or psychological reason?
So in our study, according to the scale that we have used, it includes various questions that cover both psychological as well as social aspects. So if they are growing up in a background where they are witnessing abuse happening to their family members, or they themselves are experiencing abuse, then they somehow we have found that they have grown up to be individuals who feel that this abuse is justified, or because they have gone through something similar in their childhood, they have grown up to be involved in abusive relationships. So, and also according to the socio-demographic details as well, since most of them were from low socioeconomic status and a rural background, that is what has been found, sir.
Because adverse childhood events also cause kind of personality, borderline personality.
Yes, sir. Yes, sir.
Thank you.
Yeah. The next question is by Dr. Sanjay Kumar. Was personality disorders as a cause of intimate partner violence or psychiatric diagnosis in spouses of women with mental illness considered in your study? Was personality disorders as a cause of intimate partner violence
PPT for 5 minutes,
or psychiatric
followed by
diagnosis
5
in
minutes
spouses
discussion.
of women with mental
Discussion.
illness considered in your study? As a
No,
cause
sir,
of
we did
psychiatric
not.
diagnosis in spouses of violence.
No, sir, we did not consider the diagnosis in the
5 minutes.
spouses of the ill
5
patients,
minutes discussion.
and also in the patients as well. We did have some patients who had personality issues. So, since it's a cross-sectional study, so we cannot conclude whether that causal relationship, whether the personality disorder is a result of IPV, or whether IPV has led to the personality disorder.
One last question we'll go for this one. What was the childhood adverse events you found? Did you what were them?
Yeah,
List them.
Yeah.
What were the childhood adverse events you found in your study? Did you list them?
According to the scale that we have used, most commonly were being frequently slapped, hit, or abused as a kid, and most commonly also when they witness that their mother or some other female member of the family being physically abused, and also being raised up by a parent who is dependent on alcohol. So these were some of the adverse events that most common ones
Was
reported.
there any increase in one particular category of adverse event?
The most frequent was that they have witnessed that their mothers were physically abused by their fathers. That was the one that was most common.
Right. Thank you. We'll just end this. The next paper is by Dr. U. Aditya, second year MD student, Institute of Mental Health. Prevalence of alcohol dependence syndrome cases with and without delirium during the first phase of lockdown in Telangana. Dr. Aditya.
Good afternoon, everyone. Myself, Dr. Aditya, postgraduate of IMH. My study is on prevalence of alcohol dependence syndrome. Prevalence of alcohol dependence syndrome cases with and without delirium during first phase of lockdown. Alcohol use is the common condition that has been associated with severe impairments in social functioning and medical problems. About 20% of the population had been noted to exhibit alcohol abuse during their lifespan. Alcohol dependence syndrome is one of the most common researched illness among the psychiatric disorders. In India, studies show that the prevalence of 68% for alcoholism, whereas in Telangana it is about 53.9%. More than 50% of those with a history of alcohol intake had shown exhibit withdrawal symptoms on discontinuing or decreasing their alcohol use. However, only a few exhibit symptoms of severe alcohol withdrawal with delirium. In view of increase of COVID-19 cases in India, government had decided to have lockdown, complete lockdown from March 23rd, so which had led for the forced abstinence of alcohol individuals, which in turn led the upsurge of alcohol withdrawal cases. So this study was carried out with the cases reported during this lockdown period. In a state like Telangana, where there is high alcohol consumption and insight into the matter of alcohol dependence and its complications during the abstinence, gives directions to handle the situations like this in future. These are the various studies done in the past
My aim of the study is to estimate prevalence of alcohol dependence syndrome cases with and without delirium during first phase of lockdown in Telangana. The objectives are to study association between socio-demographic parameters and alcohol dependence syndrome with or without delirium, to study association between medical comorbidities and alcohol dependence syndrome with or without delirium, to study association between severity of alcohol dependence and delirium. Methodology studies setting was conducted at IMH during the first phase of lockdown, and sampling selected by convenient sampling, and it is a retrospective study. These are the inclusion criteria: male, females, and all patients in the age group of 18 to 60 years, meeting diagnostic criteria of ICD-10 for alcohol dependence syndrome, and excluded the comorbid psychiatric disorders such as schizophrenia, delusional disorder, anxiety disorders, and mood disorders, including dysthymia and non-alcoholic delirium. These are the stools, semi-structured intake proforma, and the severity of alcohol dependence questionnaire, revised clinical history of withdrawal, assessment of alcohol scale are used during the time of presentation, and data is obtained from the case records. Statistical analysis done by SPSS version 22, Spearman correlation, and student t-test, chi-square tests are used. Study procedure: before conducting the study, ethical committee approval was taken, and patient with clinical diagnosis of alcohol dependence syndrome as per ICD-10 and meeting the inclusion criteria, exclusion criteria were included, and complete social demographic details, history, general examination, and mental examination were recorded in semi-structured proforma. Severity of alcohol dependence by SADQ and severity of withdrawal by SIVA as entered in the case sheets were noted, and this data was later compiled. And coming to the results and discussion, delirium tremens falls in the most severe spectrum of alcohol withdrawal, which could potentially result in death unless it's managed promptly and adequately. So in our study, we found the prevalence of delirium in alcohol dependent individuals. It was 39.88, which was pretty high compared to previous studies. Reasons might be only severe cases were able to come to the hospital during the lockdown period, whereas mild cases didn't in the hospital. Similar to our finding, a study in Germany 2000 shown the proportion of patients with delirium tremens among the patients with alcohol dependence syndrome as 13.5. This is the pictographical presentation. And socio-demographic factors, when compared impact of socio-demographic factors between with and without delirium, there was no significant differences found. And except gender, among males, 481 presented to the hospital, 216 presented with delirium, and 50 out of 186 females presented with delirium, which is statistically significant. The rest, we have found no significance. Our study findings are in agreement with other studies, and that there is no relation between age and development of delirium in alcohol-dependent individuals. We found that individuals with medical comorbidities such as hypertension, and both hypertension and diabetes have presented a greater number of delirium cases compared to diabetes alone or without any comorbidity, which is statistically significant with p-value 0.01. Earlier, one study found elevated blood pressure as risk factor for delirium. We found a positive correlation between severity of alcohol dependence and withdrawal delirium, implies that as severity of alcohol dependence increases, the probability of delirium increases. This is in line with study by Sarkar et al., in which he found continuous drinking as a risk factor for delirium. Here in this chart, the majority of samples are clustered towards the high values, indicating the severity of dependence, whether in people presented with delirium, which is denoted as 1, whether compared to non-delirium patients, denoted as 0. Individuals with prior history of seizures or alcohol withdrawal were associated with increased risk of delirium compared to individuals without any past history, which was statistically significant. Here, the majority of cases presenting with past history are presented with greater proportion of delirium. And our findings support the results of prior studies that have found an increased risk of delirium in patients with a past history of alcohol withdrawal seizures. And individuals consuming both toddy and cheap liquor has presented more in number with delirium than individuals taking toddy alone or cheap liquor alone or either of the substance with nicotine. Even though consumption of toddy is more in our state, delirium presentation is more in individuals consuming cheap liquor because it contains more amount of ethanol and trace alcohol, ultimately leading to the complications with abstinence. And this slide showing the mean scores of dependence. In males, it is 21.53 SATQ score and females 18.20. And this finding is also statistically significant with p-value 0.000. A positive correlation was found between the duration of intake of substance with delirium and number of drinks per day with delirium, which was statistically significant. And this finding was against Wetterling et al., in which they found no correlation, whereas it is in line with Sarkar et al., in which he found positive correlation between number of drinks per day with delirium. This is that study finding. These are my study findings. And limitations of the study: the current study is a retrospective study gathering information from case sheets, hence there might be a chance of information bias. And to conclude, the study, past history of withdrawal and type of substance, duration of substance intake and number of drinks, presence of periodical coma emerged as significant clinical predictors. Thank you.
Any questions from the audience?
IMH only, no?
Yes, sir. But during the
correlate it to whole Telangana because other districts are there where we are also treating in other.
Yes, so that's why I have written limitation. We can't attribute to prevalence.
The title probably you should not keep it as Telangana. That's
Yes,
what
but
You have used the word alcoholism in the first slide. Prevalence of
Yes, sir.
alcoholism 68%, Telangana some 50%. What do you mean by alcoholism? Is that word used still?
it was used earlier, sir, and it is taken from the National Health Survey India-wide. So whoever using the alcohol, that represents the complete alcohol use, sir. So it is total abuse. It can include abuse, use, and all the things. Yes, sir. Overall things.
The same is repeated in one of the questions, Dr. Sam. In your study, was the type of alcoholism like early alcoholics or versus late alcoholics who had more delirium tremens?
Sir, we have taken the patients who are all alcohol dependent individuals as per criteria involved, and we didn't see either early onset or late onset.
Types of alcoholism was a regular pattern versus binge pattern was associated with more delirium. Which pattern of alcoholism was associated, regular pattern or binge?
In our study, we didn't do, sir, but in previous studies, they found that binge pattern has more propensity of chances of delirium.
What instrument did you use in your study to rule out other axis 1 diagnosis?
Sir, this is a retrospective study, and we have seen the case sheets, whatever the case sheets recorded in the case sheets as alcohol dependence syndrome, after ruling out those diagnoses.
Where physical comorbidities like cirrhosis of liver also
No
present?
such were noted, sir, because that is during lockdown, and there are very number of plenty of cases has come, and my sample was around 667. I've seen around 982 cases during that period, but out of them, I have removed few case sheets because of inadequate information and inadequate data. So altogether, it was 667. So we didn't see that things.
Okay, right. Thank you very much.
Thank you, sir. Thank you.
And we have the last paper of this award by Dr. Isha Ahluwalia. She's a final year DNB student from Asha Hospital, Hyderabad. The title of the paper is Assessment of Mental Capacity in Psychiatric Inpatients.
Good afternoon, everyone. My topic of presentation today is assessment of mental capacity in psychiatric inpatients. It's not working. Yeah, it's not working. नीचे वाला? Okay, ठीक है. Okay, yeah. So my topic of presentation is assessment of mental capacity in psychiatric inpatients. Mental capacity is a multidimensional construct which defines individuals' ability to make autonomous decisions. It is determined by several factors such as understanding information, appreciation, that is retain and weigh information, reasoning based on the received information, and expressing a choice based on relevant and adequate information. In psychiatry, usually we see that patients whose capacity is impaired are mainly seen in emergencies, high dependency units, and inpatient units. There are several strong risk factors which suggest incapacity, such as psychosis, severity of symptoms, involuntary admissions, and treatment refusal. It has been seen that approximately 40 to 60% patient presenting to emergency facility may lack capacity. As clear it may seem, detailed structural assessment should definitely be done and capacity should never be presumed, incapacity should never be presumed. India has adapted to Mental Health Care Act 2017, in which through its section 4 of chapter 2, capacity refers to capacity for mental health care, and through guidance document which lays guidelines for capacity-based approach for admissions and treatment in psychiatric practice. As per MHCA 2017, every patient has to undergo a capacity assessment before admission, and admission status, whether independent or supported, will only be determined after capacity assessment. So therefore, it's an integral part for admission to psychiatric facility. So why do we need to study this? So very often we see that there is discrepancy between clinical presumptions about mental capacity and actual capacity. Also, patients with special needs, they should be enabled to make decisions regarding their treatments, as well as mental health professionals need to shift their paternalistic approach towards treatment to right-based approach for, of the patients. So therefore, in order to study the practical implications of this document, we need this study. So the aim of my study is to assess mental capacity in psychiatric inpatient facility and to study the socio-demographic and capacity-related variables of individuals undergoing capacity assessment. So ours is an observational cross-sectional study. We included 48 patients admitted through emergency facility, and MacArthur competence assessment tool for treatment was used for studying. These are our inclusion criteria and exclusion criteria, and statistical analysis was done using MS Excel version 2007 means to calculate mean, standard deviations, and proportions. So we found that almost 85.41% of admissions assessed for mental capacity lacking capacity. We did not find any gender or age-related differences. Highest prevalence of lack of capacity is in schizophrenia spectrum disorders, and lack of mental capacity was observed more in the patients with psychotic features. So as I said, age, there's not much difference, except for the fact evidence suggests that more than 45 years, apart from the psychiatric illness, age-related cognitive decline may contribute to incapacity. Then no difference in gender. Coming to the diagnosis, most of our diagnosis, most patients had psychotic features. Amongst them also, what we found that mostly schizophrenia spectrum disorders were found to lack capacity compared to others. We also assess the number of days after which patient could be engaged into meaningful conversation, and therefore detailed structural assessment could be done. So we found that it was around 4 to 10 days post-admission that patient could be engaged into meaningful conversation, that is 85.7% of patients. However, still majority of them continued to lack capacity during this assessment. Studying the different variables of the tool, we found that around 77% of the patients could not understand regarding the disorder, and 79% could not appreciate the nature of the illness. Rest of the variables like reasoning, communication, and consistency of choice were in downward trend. So breaking down these variables, we found that patients, that is 79% of the patients who had poor understanding, amongst them almost 94% of the patients could not appreciate the illness and 71% could not reason, while the people with good understanding, they had better appreciation and better reasoning. So considering this, we can infer that if the illness, understanding of the illness is poor, it is unlikely that other variables will be present and capacity will not be there for other variables. As in the tool, it has been said that even if amongst 4 of the variables, even if one is absent, we take it as incapacity. So going back to other studies, all these studies have been done outside India, and in a systematic review, 37 papers were reviewed, wherein the population was heterogeneous, both voluntary and involuntary patients were studied, and median incapacity was found in 29% of the population. Going back to each of these papers, most of the papers had voluntary group of patients. Then coming to the studies wherein involuntary admissions were there, incapacity was as high as 40 to 60%. So in our study, we found the frequency was 85.41%, which is higher than that, higher than the other studies. As far as other studies, we also did not find any association with the demographic variables. And similar to the other studies, patients with poor understanding were lacking capacity for other variables also in our study. So to conclude, assessment of mental capacity is still not completely incorporated in the clinical scenario in Indian settings. We know that in Indian settings, for administrative convenience, sometimes most of the admissions done by relatives are termed as voluntary. However, this practice will have to change if MHCA 2017 is applied and practiced. MHCA 2070 thus promised to provide patient-centered treatment care and autonomy to patients to make decisions regarding their treatment. These are the strengths. There are no studies in Indian population. Decision-making capacity, we studied only the cross-section of the population presenting to emergency, as there is high load of incapacity there, and we studied each variables differently. Limitations is a small sample, so cannot be generalized. We only studied severely ill patients. We did not study domains such as advanced directives and ECT-related capacity assessments, and we did not do serial assessments also. So I would like to conclude by saying with advent of MHCA and correct practice, it is important to do comprehensive longitudinal studies to study its impact on treatment decision as well as outcome of illness, to understand the legal implications both for patients and mental health professionals, and to be able to make better policy which safeguard the interests of the patient. These are my references. Thank you.
Yes, any questions from the audience?
It is an interesting study. The numbers, those who have lacking capacity, are very high compared to international studies. What is the scale you have used?
So MacArthur competence.
Can you project that scale? Because from what I gather is understanding of illness is also a criteria for this thing.
Yes.
For Indian Mental Health Act, it is not necessary. The person need not agree that he has got schizophrenia or anything. And when you are testing for a specific purpose. Either for admission, he may have. For treatment, it is different. For different things, there are different levels of capacity.
Yes.
So one scale, unless we look at the scale, really we cannot comment why such high numbers have come. If the scale is very complicated, very detailed test, then if you apply such a test, it will be a disservice to the patients, because so many of them will tell that you don't have capacity. Can you project the scale?
Sir, currently.
What are the components of the scale?
Yes, sir. Sir, actually, most of our sample was severely ill, psychotic group of patients only. So that's why such a high number. That's why I said that we need more, and it's only from emergency. and not general, we did not do the voluntary patients. We only did for severely ill patients because we wanted to see whether these patients later on we found that actually lacking capacity or they were like forced admission.
No, you have tested capacity for admission.
Yes, sir.
And then, but this test has got so many things.
Sir, admission, actually, we could not do a structural interview for almost all patients. It was only, that's what I have mentioned in this other table, that a number of days required to do.
Okay, I think Naresh,
Next question, last question, only one more question. You took majority of the patients from emergency OPD. So naturally, don't you think they lack capacity, mental capacity?
So that's what the whole idea of the study is, that we are not presuming that they definitely lack the capacity. We should be doing, even if we assume or presume that there is a lack of capacity, we must do the detailed assessment as per the new MHCA 2017.
Legally, is it valid if you do mental capacity when he has come through emergency setup before his illness is settled?
That's what, sir. If the patient is coming to emergency who's violent, excited, catatonic, and could not be engaged into a meaningful communication, that means incapacity is given in those cases. That has been mentioned in the guidance document also.
Sir, ma'am, I would like to ask a question. One thing you mentioned the strength of the study as there are no Indian studies, but there is a study which was done by SCARF Foundation in 2013, in which they did the study in 503 patients, and they found that 76% patient did have mental capacity. So when you're mentioning that severely mentally ill patients were only included, did you apply any other scale like PAN-SS or CGI, any other scale to check the severity of the illness with the mental capacity?
Okay, so I'm not aware what population was that, whether it was all people.
That they were all psychotic. It was done by SCARF Foundation, so all psychotic patients were only there.
So this high number in psychotic, and what point of time it was done also, I'm not aware of it. So definitely I can go back. But even in almost all papers reviewed also, in patients who are admitted involuntarily, it is as high as 40 to 60%. 76% of presence of capacity, I'm not sure.
But if we are including patients who are admitted, like if patient is in catatonia or severely agitated, we cannot say that patient doesn't have the capacity. What we can say is patient is not in a condition to give the capacity.
That is for admission. So for admission, incapacity will be there because he cannot really tell or engage into any conversation. For later on, that's why we need serial assessment, so that if we find that the patient has resumed his capacity, then it is going to be patient's choice whether they want to continue the treatment or not.
So were the patients who were not having capacity on admission, were they assessed later, like in your study, on every single day?
Yeah, that's what I said. Almost most of these patients at admission did not have capacity. I have listed the number of days after which I could engage them into the detailed assessment.
That's the
Thank
last
you.
question.
Thank you.
Thank you very much. Thank you very much. Right, that ends the Dr. P. Raghuram Reddy IMH Alumni Award. And I'm really proud that I am one of the alumni as well. I did my MD from 1996 to 1999. And it's really a privilege to be a chairperson for this award. And it's a very prestigious award. It's instituted by the alumni of IMH. So, very good. So we'll go to the next session, which is the next award, immediately without any delay. It is Sri Sitaramaya Krishna Leela Memorial Award. The first paper is by Dr. Pendota Shweta, second year MD, Institute of Mental Health. The title of the paper is Tobacco Use and its Clinical Correlates among Psychiatric Inpatients at Tertiary Care Psychiatric Hospital, a cross-sectional study.
Good evening, everyone. Myself, Dr. Shweta, and I'm second year postgraduate from IMH. My study title is Tobacco Use and its Clinical Correlates Among Psychiatric Inpatients at a Tertiary Care Psychiatric Hospital, a cross-sectional study. Tobacco use disorder is a global health concern, and in India, about 28.6% of the population consume tobacco in any form. The prevalence of smoking was significantly higher in psychiatric outpatients. Patients with tobacco dependence also tended to use other substances. Severity of mental illness is also affected by tobacco consumption, as it was found in schizophrenia patients. Tobacco-related medical conditions comprised approximately 50% of total deaths in schizophrenia, bipolar, and in depression. Before conducting the study, we went through the literature where we found that prevalence of tobacco use was variable across different study settings, as one of the study was showing prevalence of tobacco use being 36% and the other showing prevalence being 70%. And most of the studies were showing that there was an association between tobacco use and schizophrenia, whereas in an Indian study, we found that tobacco use was higher in bipolar disorder and in substance use disorder when compared to schizophrenia and other schizophrenia. And further, there is a vast literature from the Western countries about the tobacco use in psychiatric outpatients, whereas literature in India pertaining to the same is limited. Hence, we aim to conduct this study. Knowledge about the tobacco use and its correlation with various psychiatric illness may help better understanding about the association between tobacco use and various psychiatric illnesses. It may further have treatment implications not only for tobacco use but also for primary psychiatric illness. Our aim is to study the tobacco use and its correlates among psychiatric inpatients. Our objectives are to study the prevalence of tobacco use and to correlate socio-demographic and clinical parameters with tobacco use among the study population. This is a cross-sectional study done among psychiatric inpatients at IMH. Consecutive sampling method was used and the sample size being 200, and it took 2 months duration to complete the study. Patients who were aged more than 18 years and having reliable informant and able to give informant consent were considered for the study. A total of 206 patients were admitted in the open wards were approached for participation in the study. Of them, 200 gave their consent and formed the sample size. For the purpose of the study, current tobacco use was empirically defined as the use of tobacco within the past 30 days before the assessment. And the following tools were applied to the patients, which are intake pro forma, which includes socio-demographic profile, clinical details about the tobacco use, and details about primary psychiatric diagnosis. ICD-10 was used for the diagnosis of tobacco dependence, and FTND was used for the severity of dependence. And descriptive statistics was used to tabulate frequencies and percentages, and chi-square test was used to look for association, and level of statistical significance was kept at p-value of less than 0.05. Coming to the results, our study population consisted more number of males when compared to females, and the mean age of the study population being 33 years with a standard deviation of 9.9 years. And most of the study population are Hindu by religion and more are from nuclear family. More than 50% of them were unemployed and from the urban area. The most common diagnosis being schizophrenia and other psychotic disorders, followed by mood disorders, followed by substance use disorders. And more than 40% of the study population had a use of other psychoactive substances, irrespective of tobacco use. And the prevalence of the tobacco use among the study population is 39.5%. Among the tobacco users, 88% of the participants had nicotine dependence. And among the tobacco users, more than 80% were male. And the prevalence of tobacco use was high in substance use disorders when compared to mood disorders and when compared to schizophrenia and other psychotic disorders. The most common reason for the initiation of tobacco use was being coaxed by the friends in both smokers and smokeless tobacco users. And tobacco use was high among males when compared to females, and more in married when compared to unmarried, divorced or separated, and more in employed when compared to unemployed. Tobacco use was higher in the patients who were having other substance use when compared to the patients without other substance use. Tobacco use was higher in substance use disorder when compared to mood disorders and schizophrenia and other psychotic disorders. And similarly, tobacco use was higher in mood disorders when compared to schizophrenia and other psychotic disorders. In the present study, prevalence of tobacco use was 39.5%, which was in line with the previous Indian studies, but contrast with the Western studies where it is higher. The possible reason could be the variation in cultural norms, income status, distribution, and unavailability of tobacco. Further, in the study, tobacco use is significantly more common in substance use disorders. Further, in our study, we found significant association between tobacco use and comorbid other substance use. The possible reason could be, as often tobacco use coexists with other substances and tobacco is regarded as the gateway drug for other substances. And tobacco use was significantly more in mood disorders when compared to schizophrenia. As in mania, disinhibition and substance taking behavior is more common. Smoking has also been related to the presence of psychotic symptoms in mood disorders. In the present study, tobacco use was significantly associated with male gender being married and employed because smoking by women in India is still socially unacceptable and economic independence associated with employment can be attributed for the easier procurement of tobacco. Higher prevalence of tobacco use in psychiatric population increases the morbidity and thus tobacco control measures in this population warrant immediate attention. Comorbid tobacco use in substance use disorders may hamper the success of quitting the other substance. Therefore, a comprehensive treatment approach of both pharmacological and non-pharmacological interventions is required. Coming to the strengths of our study, consecutive sampling technique was taken. We included both the genders and we assessed both smoking and smokeless tobacco forms. All the psychiatric illnesses were assessed. And limitations of our study being only psychiatric inpatients were included, therefore results may not be applicable to the outpatients. And the study was conducted in the tertiary care psychiatric hospital where patients with severe mental illness are more, hence the result cannot be generalized. Lack of the control group from a general population and no confirmatory test about the substance use was conducted. And the FTND has not been validated for use in India. Conclusion. Prevalence of tobacco use is high among psychiatric patients. Specifically, tobacco use is more in substance use disorders, followed by mood disorders and schizophrenia and other psychotic disorders. Male gender, employed, married are associated with more tobacco use among psychiatric patients. Given the harmful consequences and its association with more severe illness, a comprehensive treatment approach of both pharmacological and non-pharmacological interventions is needed to address the tobacco use. Yes, sir. These are my differences. Thank you.
Finish before time. Thank you.
This is my intake performance.
Any questions from the audience? Well, let's go for questions from the ICD-10 criteria was used for nicotine dependence syndrome in your study. You said current nicotine dependence syndrome in 70% of patients. Kindly justify.
Nicotine dependence was seen in 88% of the current tobacco users, sir. For the current study, we taken current tobacco users as who were using tobacco within the past 30 days before the assessment. Of all the patients, we have applied the ICD. So those who are meeting the criteria, so that percentage was 88%.
Nicotine may give relief to psychotic patients by acting on alpha-7 nicotine receptors, thus bringing relief to auditory hallucinations. Is it the cause for dependence?
Yes, it could be the cause, sir. It was given in the other literature also. But in our study, we found nicotine use is higher among substance use disorders, followed by mood disorders, and then schizophrenia and other psychotic disorders.
No, the specific question is, nicotine may give relief to psychotic patients by acting on alpha-7 nicotine receptors. Is that the cause for dependence? Because it suppresses auditory hallucinations.
Yes, sir, that could be the cause, sir. It was also given in other literature also. Yes, sir.
Right. Any other questions now? I think we'll stop here. Thank you very much. The next paper is by Dr. Ravi Kishore, second year MD, Institute of Mental Health, study of first episode psychiatric morbidity during the initial phase of lockdown at a tertiary care center, Hyderabad.
Good afternoon, everyone. Title of I am Dr. Ravi Kishore, MD Psychiatrist, second year postgraduate. Title of my study is Study of First Episode Psychiatric Morbidity during the initial phase of lockdown at a tertiary care center, Hyderabad. My co-author is Dr. Srinivasarao Sirisha, MD, Professor of Psychiatry. Coming to introduction, as you all know, COVID-19 caused worldwide havoc and declared a public health emergency on 30th January 2020, followed by nationwide lockdown. Citizens went through a range of psychological and emotional trauma. Due to social isolation, fear of transmission, negative news in the media, people experienced loneliness, anger, anxiety, depression, and paranoia that negatively affected the quality of life. Coming to review, many surveys conducted in India and worldwide since the inception of lockdown found that depression and anxiety were the major outcomes, with female gender being the most vulnerable population. Coming to rationale, studies done so far addresses the psychological impact of the lockdown on general population through online surveys. This study focused mainly on the patient population at a tertiary center and those who are visiting to the hospital, which shows the severity of the psychiatric manifestations. Coming to aims, the aim of my study is to identify the impact of lockdown and associated stressors and the related psychotic morbidities. The objective is to assess the relationship between the socio-demographic variables and to study the temporal association between the lockdown and psychiatric morbidities. Coming to inclusion and exclusion criteria, I have included all the newly registered first episode cases, both male and female population, and patients with past psychiatric illness and family history of psychiatric illness and with medical comorbidities were excluded from the study. Coming to methodology, this is a retrospective study conducted at Institute of Mental Health, Hyderabad. During the initial phase of lockdown, that is from March 23rd to May 31st, convenient sampling was taken and data was collected from hospital records of patients reported to IMH during the period. Patients were diagnosed based on the ICD-10 criteria and patients having adequate details in the case sheets were enrolled. Coming to results, out of the 1571 newly registered cases during the lockdown, 833 were enrolled into the study. It was observed that no major change in the number of new registrations were noticed in our institute when compared to previous year data, which was 1871, in spite of government restrictions. Whereas review cases showed up to 50% reduction in the numbers. Out of 833 patients, majority suffered from alcohol-related withdrawal, followed by acute transient psychotic disorder, anxiety, substance-induced psychosis, mania, depression, panic disorder, and paranoid schizophrenia, and OCD. I compared, when I considered age versus diagnosis in the given sample, middle-aged adults belonging to 40 to 65 years of age group suffered the most during the lockdown, especially with alcohol-related complications, which was statistically proven with the p-value of 0.000, followed by young adults of 25 to 39 years of age group. Coming to gender, males were the most affected with the p-value of 0.005 and chi-square of 23.585. As more males presented to the facility with alcohol-related complications, it was also observed that females presented more with acute transient psychotic disorder, depression, paranoid schizophrenia, anxiety and OS when compared to males in the same population. When compared to socioeconomic status, association between socioeconomic status and diagnosis was studied. Data suggested that upper, lower, and lower socioeconomic classes were the most vulnerable population, and of this upper, lower socioeconomic class was affected the most, signified with the p-value of 0.000. And coming to psychosocial stressors, out of 833 patients, 495 suffered due to alcohol-related withdrawal, with a statistically significant value of 0.000 and Kramer's V of 0.417, suggesting a strong association, followed by financial stress associated with the lockdown, and approximately 48 patients relapsed consuming to alcohol due to excessive worry about the future, and few job seekers suffered due to excessive homesickness. and fear of infection as such suffered by 63 patients. And peculiar finding in our study is that in the initial 15 days of lockdown, patients presented with alcohol-related withdrawal and later on other psychiatric complications as they were afraid about the future. Coming to discussion, our study was done in a single center and had the incidence of around 833, whereas online surveys conducted so far showed incidence of around 1000, 1871, 507 and 891. In contrast to above mentioned studies, it was observed that men suffered more during the lockdown, especially with alcohol-related complications. Reported higher rates of, whereas various studies reported higher rates of depression and anxiety, and predominant gender being female. And middle-aged and upper-lower socioeconomic classes were affected most because of the lockdown. And people suffered more due to lockdown-related stressors like unavailability of alcohol, financial stress, excessive worry about the future, when compared to the, as such, fear of infection. In conclusion, our study found that the incidence of new cases was around 1571, and the extreme lockdown acts as an extreme stressor, creating a variety of psychiatric complications in a vulnerable population such as middle-aged adults and upper lower socioeconomic class and male gender. Coming to highlights, it is the first study conducted at a single center on a patient population to address the impact of lockdown and associated psychiatric complications. Study proved statistically significant association between the lockdown-related stressors and associated socio-demographic variables that led to the majority of psychiatric illness. It gives an insight into the influence of lockdown on the mental health. Coming to limitations, it is a retrospective study, and hence we have to rely on the, I relied on the case sheets information, and this is done in a single center, so results cannot be generalized to the whole population. Future directives, many studies address psychiatric complications such as anxiety or depression can occur in the general population because of the lockdown. But this study concluded that lockdown can lead to all types of psychiatric complications in the vulnerable population. So we should look into this issue seriously and to make necessary actions before having these kind of situations. These are my references.
Any questions from the audience? Or we'll go for the online questions. There doesn't appear to be any new questions from the online as well. Yeah, there's one question. Increased incidence of alcohol withdrawal during lockdown was due to non-availability, which is expected. How does it show the impact? Yes?
So it is
increased incidence of alcohol withdrawal during lockdown due to non-availability was, I mean, which is expected. How does it show the impact?
It is expected, but it is not proven statistically anywhere. And the lockdown acts as an extreme stressor. Like even though they were alcoholics, they never came to visit the hospital. Because of this lockdown only, they visited the hospital because of non-availability of alcohol.
Right. Was the anxiety of individuals led to more drinking? Was it looked into?
Yes, sir. I have included those patients also. Like few of them, because of that anxiety and fear about the future, they relapsed drinking again. Like initial days of lockdown, there was no liquor available to the population. Afterwards, they have opened the wine shops. So at that time also people visited the facility because they were more concerned about their future and they relapsed drinking.
So there doesn't appear to be any more questions.
did you try to study separating both? Because if you leave apart alcohol dependency syndrome, because junk is all about alcohol only. The remaining the remaining anxiety disorders or the depression which you are getting are the same, similar to the previous year data, or is it more or less? Did you study
Yes, sir.
that?
Sir, actually, I didn't look into those kind of case sheets. I have inquired only about those patients visiting the hospital during the phase of lockdown only. I didn't compare with the previous cases. I only took the number, like 1871 was the previous year data and 1571 was the present data. So that tells the impact of the lockdown. Even though restrictions were there, people visited the facility.
Right. Okay, thank you. The next paper is by Kirtana Tatavarti, second year MD, Institute of Mental Health, Depression, Anxiety and Stress among domestic migrants during COVID-19 pandemic in Hyderabad.
Good evening, everyone. The title of my study is Depression, Anxiety and Stress Among Domestic Migrants During COVID-19 Pandemic in Hyderabad. It's not. It's not. Can I restart? How? Can I sit there and present? Sir? It's not. I'll sit. It's working. Can I restart? Good evening, everyone. The title of my study is Depression, Anxiety and Stress Among Domestic Migrants During COVID-19 Pandemic in Hyderabad. COVID-19 pandemic has impacted millions of people in more than one way. Abrupt lockdown and strict quarantine measures cause mental and socio-economical adversities, including depression and anxiety. However, the worst hit in this ongoing crisis would be domestic migrants who are already a vulnerable community. Domestic migrants comprise workers of families migrated as an individual or in groups, mainly on a temporary basis in search of work to urban areas within the same country. About 300 migrant workers died during the lockdown with reasons ranging from suicides, exhaustion while trying to get to their homes, and alcohol-related complications. So what makes them most vulnerable is that they're separated from their families, confrontation with stigma and isolation, rejection at host states, lacking self-confidence, difficulty to adapt to new surroundings, and most importantly, inability to follow adequate social distancing due to overcrowding households. So why do we need to do this study? Because they're a neglected population, their proneness to develop common mental health disorders, barriers to procure psychiatric consultation, prevention of more suicides, and because very little literature is available currently. So even though few studies were done, one in Chandigarh and one in Nimhans, they were limited by certain confounding factors like lack of considering previous history of mental illness and physical illness. So the objectives of my study are to assess depression, anxiety, and stress levels in the study population, to assess the domestic migration stress in the study population, to assess the COVID-related anxiety, and to assess the factors affecting depression, anxiety, and stress in migrant population. So our study was a cross-sectional study. Domestic migrants were recruited from Hyderabad, Telangana. Study was conducted from May to June 2020. Convenience sampling was done and our sample size was 70. Female and male participants with history of domestic migration and those who have given informed consent were included in our study. However, those with history of physical or medical illness and mental illness and active symptoms of COVID-19 were excluded from the study. Approval from Institution Ethics Committee was taken. Permission from the local corporator was taken. All the safety precautionary measures and social distancing recommended by guidelines were followed, and the interview was conducted in an Anganwadi. So the tools used are socio-demographic data sheet, a DAS-21 scale to screen for depression, anxiety, and stress, domestic migration stress questionnaire, and corona anxiety scale. So the data was analyzed using SPSS version 22. P-value was set at 0.05. Descriptive and analytical statistical methods were used to analyze the data. Coming to the results, in our population, 37% were females, 71% were married, 61% are employed, and 37% had history of alcohol use. So our subjects screened positive for high levels of depression, anxiety, and stress, and respectively fell into severe depression, severe anxiety, and moderate stress according to the interpretation of the scales. Even COVID-19 anxiety was significantly high, and the inference was that they needed referral to higher centers. So in our study population, females screened positive for higher levels of depression, anxiety, and stress. Subjects who were unemployed had higher levels of stress, and subjects with history of alcohol use surprisingly showed lower level of depression, and all of this was statistically significant. Coming to domestic migration stress, it was evaluated under 4 components, that is separation from families, rejection, low self-confidence, and maladaptation. The most important contributor to domestic migration stress was found to be separation, and when we did a one-way ANOVA test, it was statistically significant. We even evaluated the change in alcohol use pattern during the pandemic. Out of the 15 people who have had a history of alcohol consumption, 11 of them reported increase in consumption of alcohol. And when we did a chi-square test, this was statistically significant. The most important finding of our study is that the effect of domestic migration stress and corona anxiety on overall depression, anxiety, and stress. So we did multiple linear regression to find out the same. So both domestic migration stress and COVID anxiety together had a significant impact and were responsible for about 19% of overall depression, which was statistically significant. Also, COVID anxiety, when evaluated alone, had a significant impact on overall depression. However, domestic migration stress alone did not have a significant impact. The result was similar when anxiety was taken as the dependent variable. Both of them together had a significant impact, and COVID anxiety alone also had a significant impact. However, when stress was taken as the dependent variable, both of them together had a significant impact on overall stress experience. Also, domestic migration stress, when evaluated alone, had a significant impact on overall stress. So even though a few studies were done before, none of them have evaluated domestic migration stress before. So that makes our study a pioneer study in this field. It was also found that about 10% of the participants reported passive suicidal ideation, giving the reasons of fear of contracting the virus, not being able to meet their families, and the financial instability. This gives us an insight into the seriousness of the scenario. Also, females screened statistically significant higher levels of depression, anxiety, and stress. This is consistent with the National Mental Health Survey done in 2016, which said that females are more likely to be anxious and depressed. Unemployed subjects experienced higher levels of stress, which can be attributed to the fact that they've all lost their jobs as a result of pandemic. And another interesting finding of our study is that participants with no history of substance use had higher levels of depression than participants who had a history of substance use. So this can be attributed to the fact that a lot of them are resorting to unhealthy coping strategies to cope up with the ongoing stress and consuming higher amount of alcohol. This is in tune with a study done in Poland population, which said that about 14% of their study population had significant increase in their alcohol consuming pattern and to cope up with the ongoing stress. When compared to an online survey of the general population done during this lockdown period, the depression and anxiety symptoms in our migrant population were higher than the general population. This again proves that domestic migrants are the most vulnerable population in the scenario. So coming to the limitations, like every study, our study has limitations as well. It is a cross-sectional study, which makes it difficult to assign the causality. The sample size was restricted to a small number due to the pandemic. Generalization should be done with caution because the study was done only in Hyderabad with a lot of constraints. And coming to the implications, active screening and management of domestic migrants should be done. More research and literature should be done. Access to healthcare in host states should be mandatory for all the domestic migrants and other vulnerable communities. And prioritization. Prioritization in service provision backed up by law, including welfare schemes, should be inclusive of domestic migrants because they're clearly the most hit community. I would like to conclude by saying that even though it's unfortunate that hundreds of deaths were required to grab our attention, at least from now on, we need to focus on the mental health of these vulnerable communities. Thank you. These are my references.
Any questions from the audience? No. Right. Right. We have a question from the one scale developed in China was used. Was that scale standardized to Indian population?
It was not standardized to India as such, but a few studies have been done even in Europe and in the US because the internal consistency and valuability and reliability of the study the scale was pretty high.
The scales used in this study, are they dependent or independent on culture and educational levels?
The domestic migration stress was independent, sir. And DAS21 scale and COVID anxiety scale are also independent because COVID anxiety scale is given by, it's been used and suggested by WHO also to assess COVID anxiety.
Okay.
Sir, actually, I went near Bharat Nagar flyover, so there are all the migrants reside there. About 2,000 to 3,000 migrants reside there. But because eventually that also became a hotspot for corona, we had to restrict our sample size to 70. Yes, sir. Passive suicidal ideation, sir. So we asked after the lockdown has started if anyone at any point considered like had death wishes. No active suicidal ideation was there, but about 10% of population reported that they had death wishes.
And did you find any increase of substance abuse during that time?
Yes, sir. Out of the 15 people, 11 of them reported increase in alcohol use. We assessed only alcohol use. And yes, sir. And for that, they gave reasons of because they're not able to cope up with the ongoing stress and they're not able to go back to their families as well.
Right.
Yes.
Okay. And I mean, this is not related to the study.
Yes, sir.
Did they experience any hunger or shortage of rations?
Yeah. Shortage of?
Rations.
Yes, sir,
Grains.
because the government was not taking care of them. The place where I went, only few NGOs distributed food for them throughout the 21 days, but otherwise they were very stranded and neglected, sir. Yes.
Thank you. Study is by Satya Ganeshan, Bhaskar Medical College, MD final year. Relation of substance use to ADHD among UG students. A cross-sectional study.
Thank you for the introduction, sir. Good evening, one and all. My topic is on relation of substance use to attention deficit hyperactivity disorder among undergraduate students, a cross-sectional study. Attention deficit hyperactivity disorder is a neurodevelopmental disorder which persists into adulthood in 40 to 60% of children with ADHD. There was a significantly higher lifetime risk for psychoactive substance use disorders in the ADHD adults than the non-ADHD adults. The prevalence for possible ADHD in studies of adults with substance use disorders was 23.1%. What is the need for this study? ADHD in adolescents and young adults are expressed in terms of drug abuse, increased rates of accidents, suicidal ideation, high-risk sexual behavior, and various other sensation-seeking behavior. This study explores the bidirectional data on features of ADHD and substance use disorders. Aim to study the relation of symptoms of ADHD and substance use among undergraduate engineering college students. Objectives are to screen for symptoms of ADHD, to screen for the use of psychoactive substances, and to evaluate the relationship of ADHD symptoms to substance use. Methodology: undergraduate students of a cluster of engineering colleges in the suburbs of Hyderabad were included. Institutional Ethical Committee approved the study. Study design was cross-sectional. Consecutive sampling technique was used and 711 students were included in the study. The study duration was for 8 months. Inclusion criteria, 17 to 25 years of ages of both genders were included, and childhood diagnosed cases of ADHD, if any. Exclusion criteria, students diagnosed previously with any serious neurological illness or with major psychiatric illness were excluded. Statistics were analyzed with IBM SPSS version 22. Scales used, Adult ADHD Self-Report Scale, ASRS version 1.1 Symptom Checklist, and the Barrett Impulsiveness Scale, BIS 11. Both are reported by the students to assess inattention, hyperactivity, and impulsivity, followed by the Alcohol, Smoking, and Substance Involvement Screening Test, version 3, was administered by myself after they had completed the first two scales to assess problematic or risky use of substances. Results were substance use in our study. Prevalence of substance use in students was high at 21%. The types of substances in the decreasing order of prevalence include alcohol 19.3%, tobacco 12.8%, cannabis 3.1%, sedatives 2%, cocaine 1.3%, opioid 0.7%, amphetamines and inhalants 0.6%, and hallucinogen 0.4%. Impulsivity. The percentage of students who scored higher in the Barrett Impulsiveness Scale with a cutoff of more than or equal to 72 was 29.96%, 30% of the students, with male being higher, 74.2%, and female, 25.8%. So how do we relate this impulsivity to the substance use? The color yellow here denotes the students with substance use. So on the right side, 27.2% of the students had scored higher in the impulsivity scale compared to 18.3% who scored less in the same scale among the substance use students. When we go to inattention and hyperactivity, there are about 5.3% of the students had scored more than or equal to 4, which is the cutoff used here in the ASRS scale. How is it related to substance use? So this inattention and hyperactivity, again, the yellow color denotes the substance use disorders in students. On the right side, 42.1% of the students scored higher in the ASRS scale, which shows inattention and hyperactivity, compared to 19.8% who scored less in the same scales of substance use among the substance use people. Family history and substance use disorders. Family history of substance use in siblings was higher by 40% compared to 20.8% of history of substance use in father, in a total of students who had reported that they had used substances, which was statistically significant. Discussion. The International ADHD and Substance Use Disorder Prevalence Study, IASP study, showed 40.9% screen positive using ASRS scale compared to 42.1% screen here with the same cutoff. Leonard et al. Reported that only 5% of cases were diagnosed as adult ADHD when a confirmation scale was used following screening, which showed 8.6%. This is the limitation of our study, where a confirmation scale was not used following the screening. Impulsivity in cannabis users. In our study, there was a positive association in the scores of impulsivity and substance use in marijuana users only. Similar findings were reported in another study where chronic marijuana users exhibited significantly higher total impulsivity scores on the same scale which we had used than the non-users. So this is the table which comprises of all of the substances who had, when they had mentioned yes or no, and with the impulsivity mean scores and inattention and hyperactivity scores. They are significant for all of the substances except for the sedatives and opioids. This is the cumulative frequency graph of substance use disorders. We have from the 17 years of age, they had tried, although they had tried many substances, when they had reached 23 years of age, however, they continued only tobacco, alcohol, and sedatives. Strength. It has a larger sample size, inclusion of variety of substances used by adolescents or young adults. Referral was advised for the students with drug use problems. Limitations, a confirmation scale was not used, followed by ADHD screening scales. Although we assured to maintain anonymity, the students' apprehensions on breach in confidentiality cannot be ruled out. Summary and conclusion. Substance use. Prevalence of substance use here among students was 21%. Most common substance being alcohol 19.3% and tobacco 12.8%. ADHD, the symptoms of impulsivity was found in 30% of the students, and inattention and hyperactivity was found in 5.3% of the students. Relation of this ADHD symptoms to substance use disorder. So among the students who use substances, there were higher impulsivity rates, 27.2%. And symptoms of inattention and hyperactivity among them were higher too, 42.1% were observed. What are the future directions? A longitudinal study may be pursued to understand the course of ADHD and substance use disorder, identifying ADHD symptoms, and early management of individuals with high risk for the substance use disorders is important to prevent the negative outcomes. These are my references. Thank you. And the scales attached. Thank you.
Any questions from the audience?
Yes. Yes, sir. Yes, sir. The confirmation scale, few scales are, they have pages of questionnaires, or otherwise they patented articles, which I could not find. So this is the simplest one which I'd find. And also the previous studies have used the same to establish the ADHD symptoms, sir. Mostly of inattention and hyperactivity.
I mean, you've gone for substance use.
Yes, sir.
You haven't gone for substance use disorders.
Yes, sir.
You haven't gone that.
Sir, this assess scale, which I had mentioned in the last slide, it shows the lifetime use of substances and substance use disorder in the past 3 months of life. So I had not mentioned the risk level of each of the substances. We classified into low, intermediate, and high. So according to that, we had put for all the substances, sir.
Right.
And that only was correlated to high in marijuana users.
Thank you.
Yes, sir.
Should psychiatric evaluation be made mandatory before admission in professional colleges? Nothing got to do with your study. You can just generally answer it.
No, sir. We cannot do that. However, we can definitely help the students who come up with problems while they are in the college.
Right. Yeah, I agree with you. The basic thing is you don't screen for diabetes or hypertension before professional colleges.
Yes, sir.
Because if when they are treatable, that's fine.
Yes, sir.
I mean, if there are no other questions, then we'll end the session. Thank you very much.
Thank you, sir.
That ends the award sessions. Again, I wish to thank the organizing committee, Chairperson Dr. Ashok Reddy sir, Dr. Ephraim, the organizing secretary, for giving me this opportunity to chair the awards session. Thank you very much.
Thank you, sir, and all the presenters. Now I'd like to request Dr. Keshav Rao sir to present a memento to Dr. Naresh Vadlamani sir for chairing both the award papers. Please, sir. Thank you, sir. Now, may I request Dr. Keshav Rao sir to present a memento to Dr. Shiv Kumar sir for chairing the free paper session in the morning. Thank you, sir. May I now request Dr. Shirisha ma'am to present a memento to Dr. Keshav Rao sir, Chairman of the Award Committee. Thank you, sir. Now we'd like to hand the stage over to SVS College. Ma'am is received. To to SVS College Mehboob Nagar for the annual general body meeting. Thank you.
With this, we are ending the academic sessions of the Tspsycon 2020. Now we'll be having the AGBM. The primary hall will be SVS Medical College, but the audience will participate from online
Sure.
as well as from IMH. The link will be sent only to the members of IPS TSB, and non-members need not participate in the AGBM. After AGBM, we will be having the valedictory function, and I request the winners' names will be announced during the AGBM, whereas the prizes will be given in the valedictory function. So I request the winners to stay back, or the participant to stay back to know the results so that they can have the prizes in the valedictory function. Now I'll hand over the proceedings to the president of the IPS TSB for initiating the AGBM.
Sure.
Good evening, everyone. We will start the AGBM. A few minutes, please. It will be disconnected now. Please join AGBM link. There is a separate link. Please join AGBM link.